Tripani, Dr. Anjana Khanna, eminent faculties of the day, and our own delegates for this academic fest, TNFOG Marathon CME on heart disease in pregnancy. Anything well begun is half done. We would give the best beginning to this program by invoking Mother Tamil with the Tamil Thai Varthu, the state anthem of Tamil Nadu. I request you all to join us for the invocation. Tech team, can you please? Thank you. As a mark of respect to goddess of knowledge, it has been a custom to inaugurate every event with the traditional lamp lighting. I request our dignitaries to join us for the virtual lamp lighting and inaugurate the CME. Thank you, dignitaries. May I now request our TNFOG President, Dr. Anjalakshi Chandrasekhar Madam, to formally deliver the welcome address.
Thank you,
Madam
Dr.
is the founder president of TNFOG. She's a past president of Oxy. Madam's name is synonymous with GDM and she has innumerable papers to her bag, and there are several feathers to her cap, and the list keeps going on and on. Over to you, Anjalakshi Madam.
Thank you, Dr. Anita. A pleasant evening to all of you. Respected Chief Guest, Dr. Alka Tripani, the guest of honor, Dr. Ranjana, faculties and the delegates. I am very happy and privileged to give the welcome address for this month's Marathon CME on heart disease complicating pregnancy. Heart disease is around 8%, including the hypertension complicating pregnancy, and it contributes 2 to 4% of the maternal mortality. The physiological changes in pregnancy, they add more to the stress on the disease heart, but early diagnosis and careful follow-up can reduce the mortality and morbidity. So for this wonderful CME, we have our chief guest, whom I welcome very cordially, Dr. Alka Tripani. Can I have her Madam's CV, please? Madam is the director and head of the Department of Gynecology, Obstetrics, ART, Paros Hospital, Gurugram, and director and head of ex-professor and head of the Department of Obstetrics and Gynecology, All India Institute of Medical Sciences, New Delhi, President FOXI 2016, President GESI, that is Gynecological Endocrine Society of India 2011, and she is still continuing, and President DGES, Delhi Gynecological Endoscopic Society 2014 to 16, President AOGD, Association of Obstetrician and Gynecologists of Delhi 2013 to 14, Editor Asian Journal of Obstetrics and Gynecological Practice 1999 to 2017. She is still on the editorial board and co-chair FIGO Menstrual Disorder Committee 2016 and 18. She has a number of awards, totally 47 awards, and so many credits to herself. And with this, so much of credit, I welcome you, madam, to be the chief guest for our marathon program. And I welcome, a warm welcome to Dr. Ranjana Khanna as the guest of honor. Can I have her slide, please? She is the National Vice President of the 2017, founder President, Prayagraj chapter of ISOBAB 2021-23, ICOG Governing Council member 2021-23, President AVOS GS Allahabad 2013 to 16, Honorary Secretary AVOS GS 2011 to 2012, Treasurer AVOS GS 2018 to 2010, Organizing Chairperson National Foxy Conference, BOH the Triology Delhi 2017, Organizing Secretary National Foxy Conference, Sauma 2016 Allahabad. She was a faculty at various national and international conferences and webinars, and she has a position of national awards, Foxy Srimati Mylon Award, Save the Girl Child ASCOG 2013, and she has authored many articles and chapters in various textbooks. I welcome you, madam, for this program, and I welcome all the faculties and delegates for this wonderful CME, refresh their knowledge. I once again welcome every one of you. Thank you. Jai Hind.
Anita?
Unmute, ma. Unmute, Vanita.
Thank you, Anjalakshi Madam, for the heartfelt welcome address. May I now request our chief guest, Padma Shri Dr. Alka Kriplani Madam, who's an encyclopedia, an epitome of knowledge, to speak a few words to the audience.
Thank you so much for your kind words.
Padma Shri B.C. Roy, everything, Manita. Padma Shri B.C. Roy, Madam has got all the ones.
She's an encyclopedia of knowledge, madam, and also of the awards, publications, everything. We need to know what is there in India. We can look at the CV, ma'am.
Yes.
Thank you so much for your kind words. At the outset, I would like to thank Sampat Kumari because she has taken a lot of pains. And just now also she reminded me because I got just free from hospital. Sampat Kumari, I know you for decades and you are doing such good work. And Tamil Nadu Federation of Obstetricians, Gynecologists who have taken this responsibility. And I think it's a very novel idea. What we need to know or do is we must encourage youngsters because you see, when we are at the fag end of our career, we start going to conferences, we start, mingling with each other. And if these youngsters at this age can be put into this academic activity, so I must appreciate all the organizers, the president, secretary, this young endoscopic surgeon I saw. I'm sorry, I'm forgetting your name. So you people have this wonderful idea to involve more and more youngsters because we when I was president, I always felt that we need to bring somehow youngsters. They are very busy with their careers. They are very busy with their personal family. They have small kids. They don't come for conferences, but updating knowledge and acquiring knowledge is most important at that stage. So they should start from that time on. And what to say of this beautiful topic of heart disease in pregnancy? In my lifetime, I have seen a sea change in the profile of patients and in the management. I was a young faculty at All India Institute. We used to get so many cases of heart disease secondary to rheumatic heart disease. It was so common. And then we had a very good cardiothoracic center at AIIMS. So they were operating in our days when I was a young faculty, they used to do open surgeries, mitral valvotomy. Then it started closed. And now it became PTMC, closed in pregnancy. They are never hesitant. And then the spectrum has changed. More and more patients are coming not because of rheumatic heart disease, but corrected congenital malformations, especially septal defects. They have very good prognosis. Even these, then we have lot of, because of the referral Eisenmenger syndrome, where there is very high mortality. And now we have these cardiomyopathies and all these. So spectrum of heart diseases in pregnancy is changing. Management is improving. They are also going into minimally invasive way. So they are using such beautiful vulvotomies closed and PTMCs, these procedures, and prognosis is becoming. But believe me, I fear pregnancy with heart disease because it becomes a very serious situation. You cannot play with drugs. It is a multidisciplinary team approach. And I know our youngsters are going to give wonderful tips how to diagnose, how to manage, and how to manage pregnancy in heart disease patients. I again congratulate Tamil Nadu societies and the office bearer Sampat Kumari and her team for concentrating on such common topic, which is very important for a common practitioner. And I'm pretty sure after listening to you people, everybody will be updated, and many patients will be benefited by proper treatment and early diagnosis. Thank you for the invitation, and I really feel humbled. Thank you for the nice words.
Thank you, Alka
Thank
ma'am.
you, madam.
Thank you so much, Alka Triplani
Thank
ma'am, for reiterating the importance of heart disease in pregnancy in every day-to-day practice for common obstetricians and gynecologists. Thank you, ma'am. It really means so much to us. Now I take immense pleasure to invite our guest of honor, Dr. Ranjana Khanna madam, who is the National Vice President of FOXI. May I request you to address the gathering, ma'am?
A very good evening at the outset. It's such a pleasure to see all the people from Tamil Nadu. I was just talking to Sampat some time back and Dr. Anjal Akshi. That's such a pleasure to come meet everyone, because this way with webinars, we are coming closer and closer to each other, because it's so easy to actually meet. Though we can't physically touch, but we can at least see. So at the outset, I would like to thank Dr. Sampat Kumari and Dr. Anjalakshi for the kind invite. And I have known Dr. Sampat Kumari for so long. When I was the vice president, she was the chairperson of Adolescent Committee, and such a hardworking and dynamic Foxian, I must say. And I think she is a very well recognized figure in Foxy. And it's such a pleasure to see Dr. Alka Kriplani ji here. And I must say one thing, that she has been my friend, mentor and guide in Foxy. And I can never forget that the first conference, national conference I got as organizing secretary was by Dr. Alka herself. And for that, I'm always grateful to her. She's a powerhouse of energy, talent, knowledge, whatnot. Alka ji, you are just too good. And it's such a pleasure to meet here in this common platform. And I must say that the topic of heart disease in pregnancy is so nice, and kudos to the whole organizing team of TNFOG for organizing this webinar. So we all know that pregnancy stresses the cardiovascular system, and often it worsens the heart conditions which were already there. And sometimes the mild heart disease may actually surface during pregnancy itself. The stresses include decreased hemoglobin, increased blood volume and stroke volume, and eventually the heart rate. Cardiac output increases by 30 to 50%. These changes, we all know, become maximal between 28 to 34 weeks of gestation. During labor, actually, it is cardiac output increases by 20% with each uterine contraction, and other stresses are the straining during second stage of labor, increase in the venous blood which is returning to the heart, and of course these changes take a long time to come back to normal. In patients who are on heart valves, prosthetic heart valves, we have to be very careful that we have to remove them from warfarin, because warfarin, I think all these subjects are going to be discussed. Warfarin has to be removed and it has to be replaced by LMWH or unfractionated heparin, whatever the case be. In unfractionated parent, there's a lot of monitoring to be, which is needed. In LMWH, the monitoring needed is much less. So regarding congenital heart diseases, the regurgitant lesions are well tolerated, but it is the obstructive lesions which are poorly tolerated. But one thing is there, that we must always be in consultation with the cardiologist, because as Dr. Alka has said, that it is a multidisciplinary approach. I had one case of postpartum cardiomyopathy. I remember it was the second post-operative day, and suddenly the patient collapsed. And it was like, you know, what's happening? We were all so shattered. And then, thank God, she got diagnosed and she was treated. But look at the guts of that female. I told her, don't ever try to have another child. But after 8 years, she was in consultation with the cardiologist, and she comes back again for a second child. But this time I operated at the heart center only. I said, I will not operate at my place now. Enough is enough. So I would now looking forward to hearing the learned speakers, Dr. Rajalakshmi, Dr. Pradeepa, Dr. Sumati, Dr. Paul, and best of luck for the panel, which is to be moderated by Dr. Premlata. I was just telling Dr. Premlata that she's got a wonderful CV, because I happened to read it and I was really impressed by the academician. And now I would not like to come between the speakers and the audience. And I once again wind off by wishing the Tamil Nadu Marathon CME a grand success.
Thank you, ma'am. Thank you.
Thank
Vanita,
you.
newsletter release.
Yes, ma'am. Thank you, Ranjana ma'am, for this wonderful words and a broad outlook of the
Thank
topic.
you, Madam Ranjana, Madam. Thank you.
Welcome.
May I now request our chief guest and guest of honor to do the honors by
Release the
releasing the e-newsletter of TNFOG.
Yes, Chitrakala, you can run some pages.
This is the e-newsletter of TNFOG, which comprises of articles from all eminent faculties who are a part of the CME, and also from other faculties and distinguished people from the field. This will give you a broad perspective of every topic. Since we are focusing on one topic a month, this should be a good handbook to every practicing gynecologist, and is released with the same thought in mind. May I request all members of TNFOG to have this in your clinic and make the best use of it.
Very nice.
Thank you. Thank you, Alka ma'am, and
you.
Dr. Ranjana ma'am.
Thank you. Thank you.
Welcome, welcome.
Thank you,
so
Madam.
much.
Thank you.
Thank you so much.
Thank you, ma'am. This brings us to the end of the formal inauguration. Now we move on to the academic session proper. As Sampath madam was telling, now we have the Yuva presentation and discussion. This is a marathon wherein Yuva speakers aged less than 35, giving them a platform to showcase their talent. This is brought with an idea to motivate young speakers to speak and also gain an advantage and give them a platform so that they can move forward in their academic career. So these speakers are judged by the same set of judges, given marks, and the best speakers, all top 3, are to be judged and given prizes at the annual event. May I now request the judges, Dr. Nidhi Sharma and Dr. Vijayalakshmi Kandasamy madam, to take over for the Yuva session. Dr. Nidhi Sharma madam is a professor of obstetrics and gynecology at Sarita University. Madam is graduated and has a post-graduation by the Banaras University. She is a fellow of the Indian College of Obstetrics and Gynecology. She has been a fellow of the Assisted Reproductive Tech, has 100 index publications. May I request you to take over the session along with Vijayalakshmi Kandasamy madam. Can I have a CV, please? Madam is a professor at Chettinad Hospitals and Research Institute. She's got a long tenure of 16 years of teaching experience for UGs and postgraduates. She's an ex-EC member of OPSI with areas of interest in high-risk obstetrics, adolescent gynecology, infertility, and gynae endoscopy. May I request the judges for the session, Dr. Vijayalakshmi Kandasamy madam and Nidhi Sharma madam, to take over.
Thank you, ma'am. Ma'am, we'll now call upon the first speaker. Can I have her CV, madam? First speaker CV. Yeah, the first speaker for today is Dr. T. Rajalakshmi. Madam is DNB DGO MAS. She did her MBBS at Tirunelveli Medical College and DGO at Stanley Medical College. She did her DNB at Meenakshi Mission Hospital and Research Center, Madurai. She holds a fellowship in minimal access surgery from the World Laparoscopy Hospital at Gurgaon. Her current designation is assistant professor in the Department of Obstetrics and Gynecology at the Thoothukudi Medical College Hospital. Dr. Rajalakshmi.
Good evening, all. I thank the TNFOG for giving me this opportunity. Now I will start to share my screen.
Dr. Rajalakshmi, may I request you to be a bit louder, please?
Yes, ma'am. Actually, I couldn't share my screen. I'm checking.
Open your PowerPoint, minimize it. You will see a button green in color, share screen. Go click on it, then share your PowerPoint.
Okay, ma'am. I have opened it.
Relax, take your time, open your PowerPoint, minimize it. Once you click share screen, then you click on the PowerPoint.
Ma'am, I will log in through another one, ma'am. I have logged in. I will do in that, ma'am. 1 second.
Nidhi ma'am, if Pratibha is ready, can we ask her to do it first, ma'am?
Yes, ma'am. Yes, ma'am. I'll introduce Pratibha. Yeah.
Hello. Yeah. Good
Ma'am,
evening,
I
madam.
could share my
I'm
screen
here.
now.
Yeah.
Ma'am, I could share now.
Yeah. We'll
Yeah,
just.
okay, Dr. Rajalakshmi, go ahead.
Yeah. Ma'am, you can ask Pratibha, ma'am.
Okay.
Sorry.
Pratibha. Yeah. Happy to introduce our next speaker, Dr. Pradeepa. She's graduated from Kanyakumari Government Medical College and her MSOG from Tirunelveli Government College. And she has published papers in TNFOG. She's joined her government service in 2016 and currently working as assistant professor at Coimbatore Medical College and Hospital. Her areas of interest are reproductive medicine, adolescent gynecology, and over to you, Dr. Pradeepa, for your presentation on anticoagulants used in pregnancy.
Thank you, ma'am.
Kindly put it in slideshow mode, madam.
Yes, madam.
It's on the top next to design, transitions, animation, and slideshow.
Yes, madam, but
An issue with the.
Are you logging in from Mac or HP, doctor?
HP, madam.
Yeah,
So,
okay,
look at the bottom.
let her play.
Look at the bottom, you have the, yes, that's the point. Click it.
Yes, madam. Able to see my slide?
Yes, ma'am. Yes,
Yes.
yes, Pratibha.
We can see
Good
it.
evening, ma'am. Good evening. Happy to see all of you. Thank you. First of all, I thank TNFOG, organizing committee members, for giving this opportunity. And I thank our HOD, Dr. Manun Mani ma'am, for giving this opportunity to participate in the CME. Today, my topic is role of anticoagulants in heart disease complicating pregnancy. So I'm going to take you to this through this topic. First will be the introduction and indications and types, and what are the recommendations of anticoagulation regimes and other cardiac disorders requiring anticoagulation. And coming to the introduction, cardiovascular disease is the most common cause of indirect maternal mortality, accounting for 15.5%. So that too, in a pregnancy in women with mechanical heart valve, it is classified by WHO as risk category 3. And in pregnancy in women with mechanical heart valve, the maternal mortality rate is approximately 1% and risk of valve thrombosis is 5%. So what are the indications of anticoagulants in pregnant women, pregnant patients with prosthetic valves, pregnant patients with atrial fibrillation, DVT, pulmonary embolism, and prior history of DVT or cerebral venous thrombosis? So it is not, the management differs from managing a non-pregnant women and the pregnant women. Lot of factors come into role. Because the pregnancy is a prothrombotic state, and choice of anticoagulant, we have to give the anticoagulant according to the maternal calculation of, after calculating the maternal risk and the fetal risk. And vitamin K antagonists are safest for the mother, but for the fetus, there is lot of embryopathy, fetal loss, fetal wastage occurs. And coming to the low molecular weight heparin, it requires frequent monitoring, where in some areas the anti-10A levels are not available. Some women may require urgent delivery while on anticoagulants. So risk of maternal thrombosis is higher in the postpartum period also. So these are the facts which we have to consider while treating the pregnant women who are on anticoagulants. So coming to the classification, all of you are familiar with this anticoagulants. The two common anticoagulants we are using is the heparin and the vitamin K antagonist. So the heparin, it activates the antithrombin. Antithrombin and the heparin forms a complex which inactivates the 10A and 2A, thereby inhibiting the coagulation. So coming to the vitamin K antagonist, it inactivates the vitamin K dependent factors like 2, 7, 9, and 10. So what is the difference between the unfractionated and the low molecular weight heparin? All of you are familiar with this, but I will highlight the important points. Coming to the low molecular weight heparin have a longer half-life, and the side effects are very minimal in the low molecular weight heparin. It is partially reversible by protamine sulfate. But in case of, as the low molecular weight heparin is excreted through the kidneys, in the kidney patients, in the renal failure patients, we have to use with a caution. But the unfractionated heparin is useful in renal failure. So coming to the acetrom is different from warfarin. So with the following differences, the acetrom has a shorter half-life and more rapid onset of action and short duration of action. Whereas warfarin has an action for around 3 to 5 days, and the half-life also longer compared to the acetrom for the warfarin. So we have lot of anticoagulation regimes like giving warfarin through all trimesters and replacing warfarin with heparin in the first trimester and continuing warfarin in the second and third trimester. Third will be continuing the low molecular weight heparin for all the 3 trimesters. But each anticoagulation strategy has relative advantages and disadvantages in terms of maternal and fetal safety. But there is no anticoagulation strategy that is consistently safe for the mother and the fetus. Vitamin K anticoagulants are associated with the lowest risk of adverse maternal outcome, whereas unfractionated heparin or low molecular weight heparin was associated with the lowest risk of adverse fetal outcome. So coming to the maternal complications, all of you know that risk of bleeding with unfractionated heparin, thrombocytopenia, heparin-induced osteoporosis is around 2 to 3%, but it is less common in low molecular weight heparin. What about the thrombotic events? The 3.9% when we use warfarin throughout pregnancy. When we use unfractionated heparin in the first trimester followed by warfarin, it is 9.2%. When we use the heparin throughout pregnancy, it is 33%. Another point I didn't mention in the slide is when using the low molecular weight heparin throughout the pregnancy carries a risk of 4 to 8%. The incidence of thrombotic events when we use low molecular weight heparin is 4 to 8%. So warfarin embryopathy, what does the literature says? The incidence of VK used in first trimester, that is the warfarin embryopathy incidence when we use warfarin vitamin K antagonist in the first trimester is 0.6 to 10%. So the embryopathy risk is again dose dependent. If we use a low dose warfarin that is less than 5 mg, the risk is 0.45 to 0.9%. Risk of fetopathy, that is in this when we use warfarin in the second and third trimesters, there is a lot of CNS abnormalities, ocular abnormalities occurs. The risk is 0.7 to 2%. So the rate of miscarriage in a large series of pregnant women with mechanical valve was 26.8% in women receiving warfarin in the first trimester, compared with if the woman receives heparin in the first trimester, it is 9.2. When she receives warfarin, it is 28.6%, and rate of fetal wastage is also dose dependent. When we use warfarin more than 5 mg, it is 63.9% rate of fetal wastage. When we use an low dose warfarin less than 5 mg, it is 19.2%. So coming to the pregnant women with prosthetic valves. So the annual risk of a thrombotic event in a pregnant woman not taking anticoagulation is around 4%, while those on proper anticoagulant is 1%. So live birth rate in a pregnant woman with mechanical valve is around 58%. So according to the recent guidelines of American Heart Association 2020, I'm going to divide into what are the recommendations, what are the pre-pregnancy counseling recommendations, what are the recommendations in the antenatal period, in the intrapartum and in the postpartum period. So what are the recommendations we'll see. So class 1 recommendations. So in a women who require a valve intervention before pregnancy, the choice of prosthetic valve, whether to choose a mechanical valve or bioprosthetic valve, it should be a shared decision-making process. After explaining the risk of the mechanical valves during pregnancy and reduced duration of bioprosthetic valves in young women, it should be a shared decision-making process by the women and the provider. So any pregnant women with a prosthetic valve, any women with a prosthetic valve should undergo a pre-pregnancy assessment. That is very important. Women should be counseled that pregnancy is high risk and there is no anticoagulation strategy that is safe for the mother and the baby. Pregnant women with mechanical prosthesis should always be monitored in a tertiary care center by a multidisciplinary team. And women with mechanical heart valves who cannot maintain therapeutic anticoagulation, we have to counsel them against pregnancy. So women with mechanical heart valves and their providers should use shared decision making regarding to choose an anticoagulation strategy. Which strategy they will go into should be by a shared decision making by the women and the provider. These are all the class 1 recommendations for the pre-pregnancy counseling. And coming to the antenatal period, what are the class 2A recommendations? Previously, we will not use warfarin in the first trimester, but nowadays, as the risk is very low, the pregnant and the warfarin has a less incidence of thrombotic events. We are using a warfarin in the first trimester also. Pregnant women who requires warfarin dose of less than 5 mg per day, continuation in all 3 trimesters is reasonable after full discussion with the patient about the risks and benefits. So for the women who requires warfarin dose of 5 mg, we can either use low molecular weight heparin at least 2 times daily, followed by warfarin in the second or third trimester. If low molecular weight heparin is not available, we can go for an unfractionated heparin followed by warfarin. Though these are all the class 2A recommendations. Coming to the class 2B recommendations in the antenatal period, the pregnant women who requires a warfarin of more than 5 mg, we can either use a low molecular weight heparin in the first trimester followed by warfarin in the second and third trimester. Otherwise, other thing is we can use low molecular weight heparin daily for all 3 trimesters should be considered, but this is a class 2B recommendation. Pregnant women who requires a dose of less than 5 mg, for this women also we can continue either a warfarin for all 3 trimesters. Otherwise, we can replace by the low molecular weight heparin in the first trimester followed by warfarin for the second and third trimester. So what in the 1 week before delivery, we have to switch over from the warfarin to either of the heparin. 1 week before delivery, this is a class 1 recommendation. and 36 hours before delivery. Since I told you low molecular weight heparin has a longer half-life, so we have to switch to the unfractionated heparin at least 36 hours before planned delivery. So 6 hours before delivery, we have to stop the unfractionated heparin at least 6 hours before the planned delivery. So what is the role of aspirin? American Heart Association recommends aspirin 75 to 100 mg may be considered in addition to other anticoagulation agents if the aspirin is needed for other indications like preeclampsia. So what are the class 3? What we should not do? For the pregnant women with mechanical prosthesis, low molecular weight heparin should be administered in the place where we can monitor the anti-10A levels. So otherwise, if there is no place for monitoring anti-10A levels, we should not administer the low molecular weight heparin. That is very important. Then other anticoagulants like direct thrombin inhibitor, anti-10A direct anticoagulants is not recommended in pregnancy. There is an insufficient scientific data. What's the role of fibrinolytics? For hemodynamically stable pregnant women with obstructive left-sided mechanical valve thrombosis, it's reasonable to manage with slow infusion, low-dose fibrinolytic therapy. With a hemodynamically stable women with thrombosis, we can use a slow infusion, low-dose fibrinolytic therapy. This is a class 2A recommendation since surgery carries a high risk of fetal wastage. So whether we can use fondaparinux, yes, we can use according to ACOG. If there is a heparin-induced thrombocytopenia or heparin allergy, we can use a fondaparinux in the pregnancy. So this is the recent protocol. If the pregnant woman comes to you with a mechanical prosthetic valve replacement, you have to check whether the women can maintain the therapeutic anticoagulation with frequent monitoring. If the patient is cannot maintain the therapeutic anticoagulation, you have to counsel against pregnancy. So this is the place. The pre-pregnancy counseling is very important because at this place we can avoid the lot of mortality and morbidity which happens later. So if she can maintain, so we have to counsel against the anticoagulation regime. If she needs warfarin dose of more than 5 mg, I told you, we can continue warfarin for we have to replace with either of the low molecular weight heparin or unfractionated heparin. If she needs less than 5 mg, we can continue warfarin for all 3 trimesters, or we can replace with the low molecular weight heparin, and then we can restart warfarin for the 2nd and 3rd trimester. So this is the European Society of Cardiology recommendations. It is same, but the thing is, in the pregnant women with, I have highlighted, in pregnant women with low molecular weight heparin, it's recommended to target anti-10A levels 4 to 6 hours post-dose. Because what happens in pregnancy, there is an increased creatinine clearance and there is an increased glomerular filtration rate and increased volume of redistribution. So fixed dose regimen for the low molecular weight, we cannot opt. So we have to adjust the dose according to the target anti-10A levels. So we have to monitor, after giving the first dose, we have to monitor the anti-10A levels 4 to 6 hours later. So in the aortic valve replacement, it has to reach 0.8 to 1.2. Suppose if we
have only 1 more minute, ma.
Okay, ma'am.
Nidhi, ma'am. Time up, ma'am.
Yes,
Yeah, she has 2 more minutes.
So in pregnant women with a low molecular weight heparin, in addition to monitoring peak anti-10A levels, monitoring pre-dose targeted levels also important. And low molecular weight heparin is not recommended when weekly anti-10A level monitoring and dose adjustment is not available. It is not recommended. And for the women contemplating pregnancy, a bryoprosthesis should be considered rather than a mechanical prosthetic. So this is European guideline says we can give the warfarin more than 5 mg also in all the 3 trimesters. Only the European Society of Cardiology says like that. In all the 3 trimesters, we can give warfarin if the dose exceeds more than 5 mg also. So this is the difference between the AHA and the European Society of Cardiology guidelines. It says warfarin if the dose is less than 5 mg, we can give in all 3 trimesters. But according to the European Society of Cardiology, we can give warfarin either less than 5 mg or more than 5 mg in the first trimester. And the aspirin is recommended only by the AHA, not by the European Society. So this is the target INR levels. What happens if the women comes in a labor? So if the women comes in labor, if time in urgent delivery, if the time allows, we can discontinue the heparin and delay of 4 to 6 hours is preferred. So vaginal delivery is preferred compared to the cesarean section. If emergent delivery is necessary, protamine can be given. So how the protamine can be given? For 100 units of unfractionated heparin, 1 mg of protamine can be given. For 1 mg of enoxaparin, 1 mg of protamine can be given. So when the women on warfarin comes in labor, if there is a time, we can administer vitamin K 5 to 10 mg IV. If there is no time, if we need emergent delivery, go for a general anesthesia. Check INR. INR is more than 1.4. Go for a general anesthesia and administer either an FFP or 4-factor prothrombin concentrate. So regional anesthesia, all of you know, for the prophylactic, 12 hours for
Your time is almost up, Ma. Pradeepa? Yeah.
So 12 to 4 for the low molecular weight heparin, 24 hours, we need to, last dose has to be 24 hours before the spinal anesthesia. After spinal anesthesia, we can restart the dose after 4 hours. So coming to the postpartum anticoagulation, we can restart after 4 to 6 hours after vaginal delivery, 12 hours after cesarean section, and after 3 days, we can switch over to warfarin. Thank you, ma'am.
Okay, thanks, Pratibha. That was a very elaborate on this one. So one small question I would like to ask you, like if you were to see a patient who needs an emergency LSCS and she is already on heparin, okay, what will you do while doing the surgery? Suppose there is fetal distress. What all things, a checklist should be there. What all things you will do just before surgery, during surgery, and after surgery? Somebody who's on heparin and you are doing a cesarean section.
So I will ask when was the last dose of heparin was given, and I will note out the time and I will check the APTT. And I will check the APTT. If the APTT is normal, we can do under a spinal anesthesia. If the APTT is abnormal, we can go for a general anesthesia. And if there is protamine is available, we can reverse the anticoagulant action.
What else should you keep available? What else should you keep available when you are performing the cesarean section for this patient?
If fresh frozen plasma,
yes,
has to be available, ma'am.
Yes.
Okay. Okay. Any other measures you will do that you know during surgery to minimize the blood loss and all that you know? No basics. Any other basic things?
I'll give a prophylactic syntocinon, tranexamic acid.
Okay. No, that's not the answer.
So what is it?
Another thing. You have to prefer which one, suppose if it's a renal patient also, along with heart disease, there is a renal disease also. Okay. The renal parameters are also gone. So in renal disease patient, which one you prefer, unfractionated or fractionated?
Low molecular weight heparin, ma'am. Because, sorry, ma'am, unfractionated heparin. Because the low molecular weight heparin excretion is through kidneys. So unfractionated heparin, I'll prefer.
If in a cardiac, okay, thank you.
Supposing you have a patient with a mechanical valve which is showing thrombosis, then what is the what would the cardiologist prefer to do? Because a thrombosed mechanical valve.
Madam, we have to see whether she's critically ill or hemodynamically stable patient. If she's a hemodynamically stable patient and the thrombus is less than 10 mm, we can go for a slow infusion, low dose fibrinolytic therapy. Because
like what would you prefer to give? What is usually preferred? Because pregnancy.
Altiplase, ma'am.
Yeah. Okay. Tissue plasminogen activator, isn't it?
Yes, ma'am.
Yeah. Okay.
Okay. What is the role of sieves or filters, thrombus filters?
Mechanical filters.
Mechanical filters, yeah.
Filters, yeah.
Ma'am, I think it can be used only in deep venous thrombosis patients.
You are doing a pelvic surgery, no? Cesarean is a pelvic surgery.
I have no idea of filters.
Okay, we'll go to the next.
Yeah, thank you, Pradeepa.
Thank you, ma'am. Thank you.
Yeah.
Ma'am, we have with us Justin Paul, sir. I think he wants to give his opinion. His sir has put up his hand. Can we just hear from him, ma'am?
Yes, ma'am. Please.
Please, please.
Sorry to come in. Thanks for calling.
So we need your expert guidance on this.
Good evening. Good evening. About is it possible I can give the answer to these two questions? That is about that prosthetic valve thrombosis and the mechanical filters after my talk. Is that okay, or you want me to address it right now?
Sir, you can tell right now, sir. Please, sir.
Okay, fine. Now, prosthetic valve thrombosis, if the patient is sick, I think Dr. Pratibha has rightly said that if the patient is quite sick, we may need to fibrinolyze. Our experience with fibrinolysis in pregnancy has been about 20 patients we have lysed, and most of the patients we have used about streptokinase in about 12 patients and in about 8 patients. We don't use arteminase for lysis of prosthetic valve thrombosis. And half of the lysis have been in the antenatal period and half in the postnatal period. And most of these thrombosis have taken place during the transition from oral anticoagulants to low molecular weight heparin. And almost half of them have been due to low molecular weight heparin. So my advice at this forum is never use low molecular weight heparin unless you have a facility to monitor anti-10A activity. Now, if you look at what Dr. Pratibha has nicely shown, it is class 3 harm if you are using a low molecular weight heparin without monitoring anti-10A activities. Like many physicians think that it is very easy to use low molecular weight heparin, and as soon as the lady becomes pregnant, they switch over to low molecular weight heparin and they land up to us with prosthetic valve thrombosis. About the question on the filters do not really have a role in prosthetic valve thrombosis. I think Dr. Pratibha rightly mentioned that if you have a large DVT, iliofemoral DVT, those situations you may use an IVC filter. Otherwise, for this thrombus in the mechanical prosthetic valve, we do not really advocate any filters. In fact, there has been one report where it is non-pregnant patients where they had put filters in carotids, both the carotids, and then they have gone ahead and dislodged the valve and caught the clot that were moving up, but that was not in the pregnant patients. So filters really do not really have a big role in these patients. And how frequently anti-10A activities have to be done during pregnancy? As actually, you may need to do it twice a week in the first week. And then once you get a reasonable level, you'll have to do at least once a week during this particular period. And anti-10A levels are not available in many hospitals. And it is also about 1,500 rupees for one test. Many patients that we see in the government settings are really not affordable, and we have not practically done anti-10A levels in the government hospital, though I have done that in the public hospitals. And the role of heparin infusion is another question.
Justin Paul, sir. This is good evening, sir. This is Dr. Sampath Kumari.
Good evening, madam. Good evening, madam. Good evening.
First session is for you. You are a master of cardiology. So first
madam, sorry, madam. I'm sorry. I apologize. I get away because that's why I said, shall I ask it later or not? Let you ask him. I was so happy to see Pratibha because Pratibha was so wonderful. When I went to Coimbatore, madam, when I went to Coimbatore for the pregnancy and heart team meeting, Pratibha does a great job. She is well supported by her HODs. So I will move away and let the Yuvas take the forum.
Thank you, sir. Thank you, sir. Your registry made me to involve in the heart disease patients. After your registry TNPHDR app, after entering all the patients the TNPHDR app only, we are aware that a lot of cardiac patients are coming. So it's very useful for us, sir. Thank you, sir.
Thank you. Thank you, ma'am. Because this is like a competition, sir. So I thought let the other competitor finish.
Thanks,
okay,
madam. Thank you.
Thank you, sir. Nidhi Sharma, you can proceed.
Yes, ma'am. Ma'am, next speaker we'll call upon, madam.
Yes.
Good evening,
Lakshmi.
Yeah. Good evening, ma'am. Yeah. Thank you for giving me this opportunity, ma'am. Today we are going to discuss about the pathophysiology of the normal and the heart disease in pregnancy. Yeah. First of all, what to say, the heart disease constitute about 2 to 4% of all the 1 to 3% of all pregnancies, and it is it contributes significantly to the maternal death in our country. We all know that rheumatic heart disease is actually declining in the worldwide, but now in India still it's a common cause. But we are also seeing more of a surgically corrected congenital heart disease, and they all contribute significantly to significant morbidity and also an ICU admission. We as an obstetrician should be able to diagnose, and also we should initiate the management of medical complication in those patients. So our knowledge of the physiology is very important in diagnosing and managing these cases, and it's actually a team management involving the cardiologist and anesthetist too. First, we are going to see about the anatomical changes. We all see that where the blue line represents a non-pregnant individual and the black line is in the pregnant individual. When the uterus grows up to that, the diaphragm is pushed upward. So the heart is actually displaced to the upward, and it is rotated, and it is displaced upward, and it is rotated to the left. So there is a upward and outward and a left rotation. So the apex beat is actually shifted to the left in a fourth intercostal space in the mid-clavicular line. In also because of the increased cardiac output and the stroke volume, there is a spherical eccentric hypertrophy of the heart, and there is an increase in heart size of about 12%. This can be seen in the chest X-ray as an apparent cardiomegaly and a straightening of the left heart border. Coming to the hemodynamic changes, the first parameter that we are going to see is the blood volume. The blood volume, as you can see here, start increasing from as early as 10 weeks. It is due to both increase in the plasma volume and the red cell volume, and it all increase maximum during the 28 to 32 weeks, and it remains plateau till the term, and it decreases during the postpartum period because of the autodiuresis. The next factor which increases is the heart rate. It's due to it is increased by almost 10 to 15 beats, that's 17%. During labor, it further increases due to stress and anxiety, and due to in postpartum, it decreases to the normal value. Next factor is the systemic vascular resistance. Pregnancy is a storm of hormones involving the progesterone, nitrous oxide, prostaglandin. All these will have a smooth muscle relaxing effect. So the systemic vascular resistance decreases, and thereby the blood pressure decreases in the second trimester and remains the same. And after postpartum, it decreases for up to 2 weeks. In coming to the stroke volume, this is the next factor which is determining the cardiac output. It increased in the first and second trimester, whereas in the third trimester, it decreased due to compression by the gravid uterus. During labor, it's almost increased by another 20% of due to contraction of the uterus. Another 300 to 500 ml is increased. So as we can see here, next we are going to see about the cardiac output. Cardiac output is equal to stroke volume into heart rate. So as we have seen before, both the heart rate is also increased and the stroke volume is also increased. So here the cardiac output is increased by 30 to 50%. Mainly it is due to an increase in preload due to a greater blood volume as we have seen, and there is also an increase in the maternal heart rate. So the decrease in systemic vascular resistance will lead to a decrease in afterload. All these factors will increase the cardiac output by almost 30 to 50% above the baseline. During labor, what happened during labor? There is an additional 50% increase in labor pain and uterine contractions. After delivery, what happens is there is a relief of vena cava compression after delivery, and also because of the auto transfusion of the blood, this contributes to an increased cardiac output. After postpartum, it slowly decreases to the normal values. And the blood pressure, as I mentioned before, due to the vascular resistance, the blood pressure is actually lower during the pregnancy. As you can see in this graph, we can see that the maximum is between the 28 to 32 weeks, and it is during the second stage of labor when the woman is pushing hard, the further output is increased so much. And immediate postpartum period, because of auto transfusion and diuresis, it is furthermore increased. So what happens is the normal pregnant woman is able to go through all these hemodynamic changes. But when it comes to the already compromised woman with a heart disease, or previously the woman would not have any symptom, but she might have had heart disease in her, that will come into evident only during the pregnancy period. As you can see here, there are 5 phases during the pregnancy when there is a danger of cardiac decompensation. The first one is between the 12 to 16 weeks when the hemodynamic changes of the pregnancy begin. And the second one is between 28 to 32 weeks when it peaks actually. And also the demands are maximum during that time. And third one is during the labor when additional 300 to 500 ml of blood is injected with each contraction. And also after the delivery of the placenta, as I have said before, due to relief of compression of IVC and auto transfusion. Here we will have some amount of blood loss also, and also auto diuresis, everything will happen. So the heart has to undergo the hemodynamic changes variantly. That is, there will be decreased output, there will be increased output. As already compromised heart will not be able to tolerate such things. And after 4 to 5 days after delivery, there may be sudden death. It's most commonly due to the pulmonary embolization or due to a right to left shunt with Eisenmenger syndrome. So when a woman, that's why we need to maintain, we have to prevent infections, anemia, hypertension and thyrotoxicosis, all those things, anything which increase the cardiac output and also fluid overload, any factors which either increase the cardiac output or the heart rate actually leads to heart failure in pregnancy. And next to the just a few physical signs which you can see that when we look into it, there will be, due to the increased blood flow, we can have an exaggerated splitting of S1, loud S3, and ejection systolic murmur in pulmonary area, and there will be a continuous flow through the mammary vessels. Looking to the ECG, actually because of the sinus tachycardia, there will be an increase in the heart rate. So there is a reduction in the PR interval. Also, there is the appearance of a Q wave and a flattened or an inverted T wave also present. And there could be a 15-degree left axis deviation as the heart is pushed upward and outward. The last thing about the hemodynamic changes, there is one important thing that's called the effect of posture, which will lead to a supine hypotensive syndrome. As we can see in this picture, what happens in the supine position is the pregnant uterus actually compresses the inferior vena cava and also the aorta. So what happens is there is a decreased venous return. So there is a decreased cardiac flow, there's a decreased preload, so decreased cardiac output, and the uterine blood flow is also decreased. When the woman turns to the left lateral position, see, as you can see here, the uterus goes out and there is a relief of compression. So there is an 20% increase in cardiac output. So in a laboring patient, this increases the oxygen saturation. So that's why we always have the woman in the left lateral position. So coming into many of the symptoms of cardiac disease, the symptoms of pregnancy actually mimic the cardiac disease. As we all know, many of the pregnant women actually have commonly, they will present as dyspnea, fatigue, edema, heartburn, and palpitation. But there are certain features which indicate a heart disease. This includes that orthopnea, when a woman complains that she's not having dyspnea and lying down, and paroxysmal nocturnal dyspnea, we should think of heart disease. She may have nocturnal cough, hemoptysis, severe chest pain, and syncope. When you're examining the patient, you can have, normally in pregnancy itself, we can have some amount of neck vein pulsation because of the increased blood volume. And there could be a systolic murmur, but it's usually less than grade 3. Here there will be a neck vein distension and systolic murmur will be more than grade 3, and the presence of diastolic murmur always diagnoses it as a heart disease. In a normal pregnancy, there is a displaced apex beat only, but in here there will be a definitive cardiomegaly. And when we come into the heart sound, third heart sound is normally heard, but here there is a loud P2, wide split S2, and a fourth heart sound. And then the ECG always shows a sinus tachycardia, but here there may be persistent arrhythmias can be present. Finally, when you are going to see about the fetus also, it will usually cause because of the inadequate uteroplacental circulation, spontaneous abortion, IUG, prematurity due to inductions are also common. And when a woman with congenital heart disease, there's a genetic, most of them will have a genetic reason. So those siblings, the children are more likely to have an increased risk of congenital heart disease. And in cyanotic heart disease, fetal death is also more common. So coming into the specific heart diseases during the pregnancy, the more common one, as we can see in India, is the rheumatic heart disease or the acute heart disease. Among it, we know that mitral stenosis constitute about 85% of all the lesion, and it's one of the common lesion, and we day to day we encounter the mitral stenosis. So the main cause is due to the rheumatic fever, and it also could be congenitally associated with the Lowton-Becker syndrome when it is associated with the aortic septal defect, or it could be due to a Coxsackie-B virus myocarditis. What we need to know in this mitral valve is, we all know the normal mitral valve area is actually 4 to 6 centimeters square. When it becomes less than 2.5 centimeters square, the woman will start developing symptoms. As you can see here, the mitral valve is the way where the blood flows from the left atrium to the left ventricle. In mitral stenosis, what happens is only a less amount of blood is able to go into the left ventricle. So what happens is the pressure gradient across this area will increase. So the left atrial pressure is increased. Also, due to accommodate the increased volume of blood, the left atrium will start dilating. Then to compensate the left atrial pressure also. This will lead to an atrial fibrillation. And when the left atrial pressure rises, what happens is the pulmonary veins is actually equal to the pressure of both of them are equal, left atrium and pulmonary vein. Now the left atrial pressure will be transmitted to the pulmonary vein. So what happens is the pulmonary venous pressure is increased. So there will be a pulmonary congestion. More amount of blood will be stagnant in the pulmonary vein. So it will lead to a pulmonary edema and congestion. So any factor in pregnancy which increases the, so even the pregnancy is a state of increased cardiac output. So what happens is there's a more amount of blood, so more stagnation of blood. So actually pregnancy aggravates the symptoms of mitral stenosis, and many women actually present for the first time with symptoms during the period of pregnancy only. What happens is that after the pulmonary venous hypertension, finally there will be a pulmonary artery hypertension. When the pulmonary artery hypertension develops, the right ventricle has to work more. So there is a right ventricle hypertrophy, and finally she can present with the right ventricle failure. So these are all the clinical features which I have already told you. So you can present with dyspnea, fatigue, palpitation, cough, and there will be a low S1 and P2. The next common.
Dr. Rajalakshmi, you have another 1 minute to go.
The next lesion is the aortic stenosis. It's due to a congenital bicuspid aortic valve or rheumatic heart disease. As you know, here the normal valve area is 3 to 4 centimeters square. Here the ejection fraction, there's a fixed stroke volume is the pathology. As the left ventricle has to push through the stenosed aortic valve, more amount of blood is stagnant here and the ventricular pressure increases. So there is an increased ventricular pressure, ventricular wall hypertrophy. This decreases the compliance of the left ventricle, and the left ventricular end diastolic pressure increases. So what happens is there is a decreased myocardial perfusion. So these women will present with angina, syncope, and dyspnea. The main problem with aortic stenosis is they will not be able to increase the cardiac output with any need. Any woman, when they want to increase their output, actually it is not able to input. So they are actually managed on the wet side during that, so that when more amount of fluid is there, they are able to push it. So hypotension and hypovolemia should be avoided in aortic stenosis. Mitral regurgitation and aortic regurgitation, both of these lesions are actually well tolerated because the decreased systemic vascular resistance will favor a more forward flow than the regurgitant flow. So these women will both are well tolerated during the pregnancy and they don't have any problem. They will go through the pregnancy. Coming to the pregnant women, actually Pratibha has discussed about this more. The main problem with bowel processes is they have need for anticoagulation. So they are more prone for thromboembolism, hemorrhage of anticoagulation, and cardiac function deterioration. Then lastly, when I'm going to tell about the congenital heart disease, now the incidence is rising. In congenital heart disease, the main factor we need to know is the Eisenmenger syndrome. What is it? When the pulmonary vascular resistance is higher than the systemic vascular resistance, there will be a right to left shunting. So when we can see here, it usually occurs in AST, VST, PDA, and atrioventricular septal defects. Normally, the blood flows from the VST, left ventricle, to the right ventricle. But what happens is because of that increased flow, there is an increased pulmonary blood flow. This increases the hypertension. Pulmonary hypertension will develop. When this pressure exceeds that of the left ventricle pressure, the blood will backflow from the right to left. So deoxygenated blood actually mixes with the left ventricle, and there will be hypoxia and erythrocytosis. So what happens in AST, VST, and PDA? Actually, these women are actually well tolerated during the pregnancy. The one thing which determines the outcome is actually the pulmonary hypertension. So any woman in the AST, VST, PDA without pulmonary hypertension are able to go through the pregnancy. And when lastly about the cyanotic heart disease, we know these are all some of the cyanotic heart disease we can see during the pregnancy. The most common will be the corrected tetralogy of the Fallot. These women actually having cyanosis and hypoxia. What happens is most of the women are corrected during childhood. They will go through pregnancy. But those with uncorrected right to left shunt, they develop heart failure and stroke. And the live birth rate is actually only 43%. The determinants of here are the oxygen saturation, which is more than 90, which should be at least 90, and the hemoglobin level should be at least less than 20. These are the factors which are going to determine the outcome in the cyanotic heart disease. The last thing, a few words about the peripartum cardiomyopathy. What it is, it's actually, we have known the many women with in the postpartum period, they will present with a sudden collapse, and we couldn't find the reason. They will usually present with symptoms like weakness and cough, orthopnea, chest pain, palpitation, and a sudden collapse. We couldn't diagnose, and it's actually a diagnosis of exclusion. After ruling out all causes, only we can tell it's a peripartum cardiomyopathy. It is characterized by a right and left ventricular enlargement and also a reduced systolic function. And when we look into the diagnosis, what is there in echo? There will be a decreased ejection fraction because of the dilatation of all the ventricles. It couldn't pump more, and there will be a decreased ejection fraction. And then diastolic dimension, there is the ventricle dimension will be more than 2.7 centimeter per meter squared. So finally, to finish, the key points we need to know are the hemodynamic changes in pregnancy and labor actually compromise the cardiac function in women with heart disease. We know that normal signs and symptoms, actually the normal pregnancy, most of the symptoms will mimic the cardiac disease, but we should be able to pick up and diagnose the woman with heart disease so that early intervention will prevent the mortality and the morbidity. And we all know the few complications, and understanding all this physiology will help in diagnosing and treating the emergencies. Thank you.
Okay, thanks, Pratibha. That was a very elaborate talk. Okay, the slides are also very good and discussion is nice. One small question I have for you. What is, if there was one investigation which you will like to do to prognosticate the patient, what will you do in the antenatal period and when will you do it?
One investigation for
one investigation.
Echocardiogram.
Echocardiogram. What all things will you like to see and when will you do?
Actually, echocardiogram is advised during the end of the first trimester because this is the time when the woman can start developing the symptom. We should look for the valve area. We should look for the valve area and the ejection fraction mainly.
Okay. Then when will you repeat it?
In 32 weeks when the peak changes will occur.
Okay. So if at 32 weeks it is all right, then what will you do?
Then she is normal, ma'am, because the main demands everything are maximum at 28 to 32 weeks.
Do you know the role of routine echocardiography these days?
Actually, routine echo is must during pregnancy because we, as an obstetrician, we really encounter every day more. Still, we are losing women with heart disease. They have to encounter a process like a labor, delivery, cesarean section. They have to go through anesthesia. So they have to face more complication during delivery also. So it's needed. It's compulsory actually.
Yeah, it should be done. Okay. Okay. Ejection. Can you tell what is TAPSE and MAPSE? PAPSE. PAPSE and MAPSE. Actually, you told about peripartum cardiomyopathy, no?
Yes,
so we had one patient like that. So peripartum cardiomyopathy, we could prove it that this postpartum complex is because of peripartum cardiomyopathy. So any other any things in the echocardiography which you can tell, findings in echocardiography for cardiomyopathy?
For peripartum cardiomyopathy, actually the ejection fraction is lower, ma'am. As I have told before, we have seen, no, ma'am. You are saying that or any other? I don't know about TAPSE, ma'am.
That is systolic excursion of the valves. Mitral valve systolic excursion and tricuspid valve systolic excursions. Okay, another thing. You said pulmonary arterial hypertension, isn't it? Any drug can you tell? Any drugs commonly used?
Sildenafil.
Melrinone?
Yes, ma'am.
How does it act? How does it have a mechanism of action of sildenafil?
Phosphodiesterase inhibitor, so it will relax the pulmonary vessels.
Yeah. Thank you. Ma'am, you want to ask something, ma'am? Vijayalakshmi?
Yeah. Supposing you have a woman with PPCM, can she go through another pregnancy?
We have to explain her that is a very high risk. The mortality rate is very high during the next pregnancy. It could be determined only by the ejection fraction at the end of the 6 months of pregnancy. When the ejection fraction is lower, less than 45%, even at the end of 6 months, we have to tell her it is contraindicated. Otherwise, with the risk explained, she can, with the cardiologist intervention, if the ejection fraction has improved in the after 6 months, she can have, but she should be monitored closely for, and there is a 50% risk of recurrence in the next pregnancy.
Yeah. So she should always be monitored at a tertiary care center where the cardiac facilities are fully available. Because we've had a woman who went through another pregnancy, desirous of. What about Eisenmenger syndrome? If you encounter a woman with Eisenmenger syndrome in the first trimester, what will be your recommendation?
Actually, pregnancy is contraindicated in Eisenmenger syndrome because surely even when you are
you meet her during the first trimester. You see her during the first trimester.
Okay, I will advise her termination. But I will also tell her even this termination during the first trimester can affect her health, that she can have cardiac failure even with the first trimester termination. But I will advise termination.
Thank you, Rajalakshmi.
Thank you, ma'am.
Thank you.
Nidhi Sharma and Dr. Vijayalakshmi, thank you so much for your constant support.
Thank you. Thank you,
so
Sampath,
much,
madam.
Vanita, you can go with the second session.
Yes, ma'am.
Thank you,
Nidhi,
Rajalakshmi and Pratibha.
madam.
Thank you, ma'am. Thank you so
And
much.
Dr. Rajalakshmi and Dr. Pradeepa for this wonderful, elaborate discussion on your topics. We now go on to the quiz time. We have a question for all the delegates.
Faculties are not eligible to answer.
Madam, I said only delegates.
Only delegates.
Tech team, can you please, yeah. The following are the complications of anticoagulant except bleeding, osteoporosis, and thrombocytopenia. The person who gets to give the first correct answer will be judged the winner. I request the delegates to post their answers. Can we close the poll? I repeat, the following are the complications of anticoagulant except bleeding, osteoporosis, and thrombocytopenia. Kindly make only a single choice. Yes. We now move on to the next session. May I call upon Dr. Chandra Ponusamy, madam. Madam has done her undergraduation, post-graduation from Stanley Medical College, and madam has several gold medals to her credit. She's the best outgoing student of her batch. She's the first OGCN, sonologist, histolaparoscopist, and first IVF specialist in the district. She's a Foxy Life member since 1981. She's a founder member of Salem UG Society. She's a life member of IMA, Image, and IZAR. She was a vice president of NIMA. She's instrumental in formation and founder president of the Nomical OG Society. Hearty welcome to you, ma'am.
Thank you.
May I also invite Dr. T.S. Meena, madam, who is a UG and PG teacher for the past 25 years. She's a professor and head of the Department of Government Keithpark Medical College. She's a master trainer for NCT screening programs with special interest in high-risk obstetrics, social obstetrics, and cancer screening. We welcome you, ma'am, to take over the next session.
Yeah. Thank you, Anita.
Thank you, ma'am.
Thank you, Dr. Vanita. Now, can we start the session? Somebody close the quiz.
Sajita, stop sharing. Yes. Meena, if one of you can introduce Sumati, no?
Yes, okay. Good evening, everybody. And it's a nice opportunity to introduce Sumati Senthilkumar. And she is a director and consultant in OBG SS Medical Center, Salem. She developed the Department of OBG at Manipal Hospital, Salem in 2006. She had 24 years of experience in OBG, including 4 years of experience in UK. She attended many courses in UK and India. published case reports in the Journal of Obstetrics and Gynecology. She underwent training in gynec endoscopic surgeries and infertility in the UK. A special interest infertility, gynec endoscopy surgery, myomectomy, and high-risk obstetrics. And she is awarded MRCOG by RCOG 2004 and PGA in ART 2006 and FRCOG by RCOG in 2016. She has master's certificate in ART and reproductive medicine online course. And she is a receiver of STAR 2015 award by NIC Academy Chennai in February 2016 and Rajiv Gandhi Gold Star Millennium Award in 2016. And also she is the course instructor and OG SOS secretary. She was the secretary in OG SOS, the vice president and president. Welcome, Dr. Sumati. Now the stage is yours. Yeah, you can start, no, Sumati?
Dr. Sumati? Dr. Sumati?
You have to unmute yourself. Sumati? Sumati, please unmute yourself.
Can you hear me?
Yeah.
Yes.
Can you see my slides?
No, ma'am.
No?
Hello,
No?
Sumati. Good
Can
evening.
you see my?
No.
No, ma'am.
Share your slides, Ma, Sumati.
Yeah.
Yeah.
Yes.
Sumati.
Now,
Yes,
go
yes.
to the
Now,
slide
can
show.
you see?
Yes,
Go
yes.
to
Yes,
slide
ma'am, we
show,
are
Ma.
able to see it. Could you please put it in slideshow mode, ma'am?
Yeah. Now?
Yes, ma'am.
Can you?
Okay.
Yeah.
Thank you. Good evening, everyone. I thank Dr. Chandra Madam for the nice introduction. At the outset, I would like to thank Dr. Sambat Kumari Madam and TNFOG for this opportunity. And also, I'm very happy to see Dr. Alka Madam and Rajana Madam and also to be a part of this program.
And welcome, Sumati.
Thank you. Thank you, Madam. So as we know, the maternal heart disease is a major threat to safe motherhood and women's long-term cardiovascular health. Incidence of pregnancy in women with CHD and acute heart disease is on the rise. There is a rising trend in maternal deaths due to cardiovascular disease all over the world. 10% of the maternal deaths are due to cardiac disorders in developed countries. As we know, rheumatic heart disease is so common in India. However, incidence of myocardial infarction, ischemic heart disease, and peripartum cardiomyopathy are increasing here. Overall, cardiac disease have risen due to advanced maternal age, obesity, hypertension, diabetes, multiple pregnancy, and also increased survival of babies operated for congenital heart disease and awareness of investigating women with symptoms. So, what are the other contributing factors for increase in morbidity and mortality due to MHD? Number one is lack of pre-pregnancy CVS assessment and correcting the defect or optimizing the cardiac function. Second is delay or failure to identify cardiovascular disease risk factors during the antenatal care. Third is gaps in high-risk intrapartum care. And fourth is delay or failure in recognition of CVS disease symptoms during puerperium. So the previous speakers spoke very well about the CVS changes during pregnancy and anticoagulation. So as we know, plasma volume, cardiac output, pulse rate, all are getting increased during pregnancy, and it takes at least 3 months to get normalized to pre-pregnancy state. So pregnancy stresses cardiovascular system. The stresses are reduced HB, increased blood volume, stroke volume, and heart rate. So cardiac output increases 20% during each contraction and during straining. That causes increased venous return to the heart from the contracting uterus. So it often worsens known cardiac disease and mild heart disease may first time manifest during pregnancy.
Yeah.
So we know the symptoms and signs of heart disease in pregnancy. Most of the symptoms will overlap with normal symptoms of pregnancy. So we need to be aware of all these things. So heart failure, we know it can cause miscarriage, IUGR, IUD, premature labor, arrhythmias, and thrombosis. Then we have to be aware of this NYHD classification. We know 1, 2, 3, 4. 1 is no symptoms, no limitation in ordinary physical activity. 2 is mild symptoms on the ordinary activity, and 3 is marked limitation even with the mild exertion. They are only comfortable at rest. 4th is their symptoms are there even during rest. So if you see arrhythmias, the important points in arrhythmia is atrial fibrillation may accompany cardiomyopathy or valvular lesions. Rate control is very important in case of arrhythmias. It is as in normal pregnant patients with beta blockers, calcium channel blockers, or digoxin. Only we have to be aware that amiodarone should be avoided because of this fetal thyroid toxicity. Cardioversion may be used to restore the sinus rhythm for new onset atrial fibrillation or hemodynamic instability, or drugs do not control ventricular rate. Anticoagulation with standard or low molecular weight heparin should be given in case of arrhythmias. So as we know, pregnancy itself increases the coagulative state and risk of thrombosis more likely. We know LMWH and heparin do not cross placenta, but LMWH is less risk of thrombocytopenia. This was Dr. Pratibha dealt this very nicely. Warfarin, it crosses the placenta, it can cause fetal abnormalities during the first trimester, but the risk is dose dependent. Incidence is very low if the dose is less than 5 milligrams per day. Warfarin use in the last month of pregnancy has some risk because rapid reversal is difficult in warfarin anticoagulation in case of emergency. But however, if you keep protamine, vitamin K, FFP, then we can revert. Management of acute supraventricular tachycardia and ventricular tachycardia are as in normal non-pregnant women. Regarding endocarditis prophylaxis, for pregnant patients with structural heart disorder, indications and use of endocarditis prophylaxis for non-obstetric events are the same as those for non-pregnant patients. American Heart Association guidelines do not recommend endocarditis prophylaxis for vaginal and cesarean deliveries because the rate of bacteremia is low. However, in the highest risk patients like prosthetic heart materials, previous history of endocarditis, unrepaired congenital cyanotic heart lesion, or a heart transplant with valvulopathy, prophylaxis is often considered when the membranes rupture, even though no evidence indicates any benefit. If patients with structural heart disorder develop chorioamnionitis or urinary tract infection requiring hospital admission, the antibiotics used to treat the infection should cover the pathogens most likely to cause endocarditis. So congenital heart disease, prevalence of this condition is about 1%. Deaths from congenital heart disease are fortunately uncommon. Most of them are symptomatic. Risk is not increased during pregnancy. However, we know about Eisenmenger syndrome and Marfan syndrome, the complications. Because of increased pulmonary vascular resistance, there can be sudden death during labor, during postpartum period, or even after abortion after 20 weeks of gestation. So the pregnancy is inadvisable. If these patients become pregnant, they should be closely monitored with pulmonary artery line during delivery. Intracardiac, the goal is to prevent right to left shunting by maintaining peripheral vascular resistance and by minimizing pulmonary vascular resistance. We know Marfan syndrome has got a high risk of aortic dissection, rupture of aortic aneurysm during pregnancy. That is dealt with bed rest, beta blockers, avoidance of Valsalva maneuvers, and measurement of aortic diameter with echo or required. Several recent studies have addressed congenital heart disease in pregnancy. In general, regurgitant lesions are well tolerated, whereas obstructive lesions are poorly tolerated. One well-cited retrospective study found no maternal deaths during the analysis of 90 pregnancies in mothers who had congenital heart disease. However, 17% has had pulmonary edema and 12% had cardiac events. A meta-analysis of 2,491 pregnancies in patients with CHD showed miscarriage rate of 15%, low cardiovascular event rate of 6%, 8% incident of congenital heart disease in the offspring. So So CHD is one of the most common congenital abnormalities, and majority of those affected will survive to adulthood in the large part of the development of effective corrective and palliative surgery over the last 30 years. So acquired heart disease, mainly myocardial infarction, ischemic heart disease, aortic dissection. If you see, pregnancy itself raises the risk of acute myocardial infarction 3 to 4-fold, with the risk being 30 times higher for women over the age of 40 years compared with women aged less than 20 years. We need to keep it in mind because nowadays the maternal age is getting advanced because of so many factors, especially carrier. Risk factors are advanced maternal age, more than 30 years, chronic hypertension, preeclampsia, diabetes, smoking, obesity, hyperlipidemia, thrombocytosis, and blood transfusion. Up to 1 in 13 women with myocardial infarction in pregnancy will die. Acute coronary syndromes and myocardial infarction are rare in pregnancy, 1 to 2 per 35,000 deliveries. However, unfortunately, many of these risk factors are becoming increasingly common, and most women affected will be asymptomatic before pregnancy with no history of heart disease. So the key component of good management is therefore a high index of suspicion for myocardial infarction in any pregnant woman presenting with chest pain. So any pregnant woman complaining of chest pain or heartburn, please do not ignore, do not prescribe any antacid over phone. Please, we have to examine, doctor should examine her chest and her abdomen, and then only we have to take a decision. All women with chest pain in pregnancy should have ECG and cardiologist opinion. If the pain is severe, they should have CT or MRI chest to rule out aortic dissection. Serum troponin I is helpful in diagnosing myocardial infarction. The incidence of maternal death is increasing all over the world due to acquired heart disease, and it can occur in all stages of pregnancy. Cardiac catheterization is permissible in pregnant patients with appropriate abdominal lead coverage for the mother, and fluoroscopy time should be minimized. Thrombolytic agents can be given, but the guidelines for percutaneous coronary intervention should be followed. Direct current cardioversion is also safe in pregnancy. Supraventricular and ventricular tachycardia should be treated by both non-pharmacological and pharmacological means as in the non-pregnant patient. However, amiodarone should be avoided. Permanent pacemaker should follow the standard guidelines for indications. The need to implant a cardiac defibrillator should be weighed against the need to delay this procedure until after delivery. Rheumatic heart disease. Rheumatic fever is endemic in India. A survey conducted in school children in the age group of 5 to 16 years by ICMR gives overall prevalence of 6 by 1,000, that ranging from 1.8 to 11 per 1,000. It remains one of the major causes of cardiovascular disease, accounting for nearly 25 to 45% of the acquired heart disease. Mitral valve stenosis is the most common lesion and carries the highest risk. There should be a low threshold for echo, as clinical diagnosis is difficult. Valvular stenosis, if we take during pregnancy, stenosis and regurgitation most often affect the mitral and aortic valves. Ideally, valvular disorders are diagnosed and treated medically before conception. Surgical correction is often recommended for severe disorders. Pregnancy amplifies the murmurs of mitral stenosis and aortic stenosis, but diminishes those of mitral and aortic regurgitation. During pregnancy, mild mitral and aortic regurgitation is usually easy to tolerate. Stenosis is more difficult to tolerate and predisposes to maternal and fetal complications. So mitral stenosis is the most common and it's most dangerous. Atrial fibrillation is also common in this. Prevention of tachycardia and treatment of pulmonary edema, atrial fibrillation is important in mitral stenosis. Tachycardia should be prevented so that the diastolic flow of the stenotic mitral valve can be maximized. Prophylactic antibiotics are required in certain situations. Mitral stenosis may rapidly become more severe at any time. So close observation of the patient throughout the pregnancy is very, very important. Valvectomy is relatively safe during pregnancy. However, open heart surgery increases the fetal risk. Pulmonary edema is treated with loop diuretics. Atrial fibrillation is treated with anticoagulation and beta blockers, calcium channel blockers, or digoxin. During labor, conduction anesthesia is usually preferred. Slow epidural infusion is very good. Aortic stenosis should be corrected before pregnancy if possible. Surgical repair during pregnancy has more risk, and catheter valvuloplasty is not very effective. During labor, local anesthesia is preferred, but if necessary, general anesthesia is used for cesarean section. But conduction anesthesia, that is epidural, should be avoided in case of aortic stenosis because it decreases the filling pressure, that is preload, which may already be decreased by aortic stenosis. Straining also is discouraged during second stage of labor because it also suddenly reduces the filling pressure, impair the cardiac output. So operative vaginal delivery is preferred. Cesarean delivery is done if indicated for obstetric reasons only. Mitral valve prolapse more frequently in younger women and tends to be familial. An isolated abnormality that has no clinical consequences. However, patients may also have some degree of mitral regurgitation. Rarely it occurs with Marfan syndrome and ASD. Women with MEP and resulting MR generally tolerate pregnancy well. The relative increase in the ventricular size during normal pregnancy reduces the discrepancy between the disproportionately large mitral valve and the ventricle. Beta blockers are used for recurrent arrhythmias and anticoagulation for thrombus. Peripartum cardiomyopathy, the cause is unknown in most cases. It usually presents in late pregnancy or early in the puerperium, but it can occur up to 6 months after delivery. Peripartum cardiomyopathy should be considered in any pregnant or puerperal woman who complains of increasing shortness of breath, especially on lying flat or at night. As 25% of the affected women will be hypertensive, it can be confused with preeclampsia. ECG, chest X-ray, and echocardiogram is the must to diagnose. Heart failure with no identifiable cause in puerperium, most likely it will be peripartum cardiomyopathy. Risk factors are age more than 30, multiparity, multiple pregnancy, and preeclampsia. See, one of the twin patients at 32 weeks gestation was referred a few years ago to me with a history of bronchial asthma. She was saying that no, she had bronchial asthma getting nebulized on and there was no cure. So that is the reason she was referred to me. And when I saw her, she was hypoxic and there was fetal distress. Immediate cardiology opinion was obtained. She had peripartum cardiomyopathy. And after stabilizing her, emergency section was done. We could save the mother, but we could not save the neonates because of hypoxia for the babies. So it's very important. Don't ignore the symptoms. We have to be very careful. The 5-year mortality rate is 50%. Recurrence is likely in subsequent pregnancies, particularly in patients with residual cardiac function. So future pregnancies are therefore not recommended if women have residual cardiac dysfunction. Treatment is as for heart failure. ACE inhibitors and aldosterone are relatively contraindicated, but may be used when the expected benefit clearly exceeds the potential risk. Aortic dissection. So when we talk about hypertension, we always think of diastolic hypertension, but we have to keep it in mind that systolic hypertension can cause aortic dissection and intracerebral hemorrhage. So systolic hypertension was a key factor in most of the deaths from aortic dissection. Prompt antihypertensive therapy if blood pressure becomes elevated. This emphasizes the importance of blood pressure monitoring during pregnancy. Aortic dissection is diagnosed by CT or MRI chest. It's the most common serious complications of Marfan's. Prosthetic heart valves, I think only a few points. Anticoagulation for mechanical heart valve should be adjusted because warfarin should be discontinued during the first trimester if it is more than 5 milligrams. The current guidelines support 3 approaches. First, low LMWH administered subcutaneously twice daily throughout pregnancy. Unfractionated heparin twice daily throughout pregnancy. Third thing is LMWH or heparin up to 13 weeks. Then switch out to warfarin from 13 to 35 weeks, followed by again LMWH or heparin. So individual management approaches should be discussed jointly by the cardiologist, obstetrician, and patient. It's very important. Aspirin for bioprosthetic heart valves is safe in pregnancy and need not be adjusted. Antibiotic prophylaxis for delivery is not recommended as per American Heart Association, American Dental Association guidelines. So how do you diagnose heart disease in pregnancy? It may look simple, but it is very, very important. Auscultation of the chest for any murmur crepitation should be done in the first visit for all pregnant women and that should be clearly documented in the notes. And we have to take the BP and pulse rate manually. So BP manually with sphygmomanometer and mention the side of arm side and posture, and pulse rate, manual pulse rate to assess the rhythm, rate, volume, and SpO2 in each visit. If you see the pulse oximeter nowadays, I see the sisters are taking the pulse rate in the finger pulse oximeter. That's not good. We have to feel in our hand to see the rhythm and rate and volume. Probing history during each visit and auscultation of the for any murmur and crepitations if there is any symptom. Have lower threshold for even mild symptoms in pregnancy to investigate. We have to take ECG, should get the cardiologist's opinion, echo should be done. It is better to exclude rather than missing. So now we are coming to a point, antepartum care, intrapartum care, postpartum care. So how do you monitor the patient in the antepartum period? Antenatal visit for known cardiac disease once in 2 to 4 weeks till 20 weeks, once in 2 weeks till 24 weeks, then weekly once till delivery. Continuity of the care is very important by the same consultant to pick up the new symptoms and the worsening symptoms, worsening disease. Risk assessment should be done in each visit by probing clinical symptoms, taking BP, pulse, SpO2, and auscultation of chest for increasing murmur crepitations. Frequent prenatal visits, ample rest, avoidance of excessive weight gain and stress.
Sumati ma'am, may I interrupt ma'am? You have 2 minutes left, Sumati ma'am.
Okay, rush through. Regular cardiologist review from early pregnancy itself, NT scan at 12 weeks and fetal echo at 12 weeks, genetic counseling for mother with CHD. So multidisciplinary team assessment should be done. That should include obstetrician, anesthetist, cardiologist, and neonatologist at 30 to 34 weeks to plan the care around the time of delivery and mode of delivery for all pregnant women with cardiac problem. It should be documented in the notes clearly that the care plan should include intrapartum management plan, whether cesarean section is appropriate or bearing down is advisable, and appropriate pH prophylaxis, and postpartum management like thromboprophylaxis, length of postpartum stay, and postnatal review. Intrapartum care delivery should be planned in a tertiary center care where senior obstetrician, cardiologist, neonatologist, and anesthetist with cardiology experience are available 24/7. Tertiary units should have high dependency and intensive care units suitable for the care of pregnant women. Induction of labor can be done at 39 to 40 weeks with PGE2 gel or mechanical induction in stable cardiac patients. General principle of intrapartum management is to minimize the cardiovascular stress. During labor, pain and anxiety are treated to minimize tachycardia by early, slow, incremental epidural anesthesia and assisted vaginal delivery. Now, backrest oxygen furosemide may be needed. Continuous maternal monitoring should be done. Cesarean section is usually done only for obstetric indications. Elective LSCs may be needed in orphans with aortic diameter of more than 45 millimeter, aortic aneurysm, heart failure. It should be consulted with the cardiologist. As per cardiologist's advice, we have to decide. Epidural anesthesia is safe in cardiac disease. Epidural can be given 12 hours after the prophylactic dose of anticoagulation or 24 hours after therapeutic dose. Intrapartum care, during LSCS, use the prophylactic compression sutures, avoid high-dose intosinon, use intosinon 2 units over 10 to 20 minutes, low-dose intosinon infusion that is 8 to 12 milliunits per minute, titrate carefully, avoid rapid bolus because it can cause sudden hypertension and arrhythmias. Vaginal delivery. In vaginal delivery, first stage, TED stockings, epidural, continuous CTG, prophylactic antibiotics, and maternal monitoring. Syntocinon augmentation of labor should be done with double strength syntocinon because increase the concentration, reduce the fluid overload, half the rate to reduce the total volume of fluids given. Second stage, avoid pushing cut short. Second stage, assisted vaginal delivery by instruments. In third stage, syntocinon 5 units IM or 2 units IV over 10 minutes and control contraction. Syntocinon infusion, as I said before, it has 5 units in 50 ml at 7 ml per hour or 10 units in 500 ml at 36 ml per hour, continue for 4 hours. No ergometrin, do not give ergometrin. And PPH should be managed with bimanual compression, misoprostol 600 micrograms, intrauterine balloons, compression sutures. Tranexamic acid should be used with caution. Avoid prostaglandin, PGF2 alpha and carbitocin. and strict intake output chart should be maintained. Central access and arterial monitoring may be needed. Magnesium sulfate, we can use it, titrate carefully. In preterm labor, atosuban is the first line. Injection beta-methasone can be used with caution. Avoid Ritodin or salbutamol. Pacemaker, do not use monopolar diathermy. Beware of pacemaker in unusual places like abdominal wall while doing cesarean section. Deactivate implantable defibrillators. We can use the bipolar diathermy. Postpartum care, close monitoring during immediate postpartum and cardiology follow-up for several weeks. Should be monitored closely for 12 to 48 hours after delivery in high dependency unit. Anticoagulation according to cardiologist advice. Postpartum follow-up is 7 to 10 days, 6 weeks, 3 months important. So long-term care plan is crucial. Appropriate contraceptive should be given. So contraception, natural and barrier method has got high failure rate. COC has got risk of thrombosis. POP pills with implants, injection Depo-Provera safe, and but the problem is irregular bleeding and insertion problems. Marina IUD is better compared to copper IUCD because of less chance of infection, bleeding, and ectopic. And male sterilization, vasectomy should be encouraged. Female sterilization, laparoscopy, if the cardiac status is stable, we can do the laparoscopy. Otherwise, mini laparotomy under local or regional anesthesia. Cystoscopic insertion of fissure under local and IV sedation can be done. To reduce morbidity and mortality, the first thing pre-pregnancy and premarital counseling should include all women should be assessed for any cardiac disease before planning for pregnancy. Optimization of the cardiac status and corrective cardiac surgery are necessary before pregnancy to reduce the incidence of morbidity and mortality. Successful pregnancies can be achieved when cardiac complications are managed appropriately during pregnancy. In order to optimize maternal and neonatal outcome, close collaboration between obstetrician, anesthetist, neonatologist, and the cardiologist is important. And this is a Carpet score. You can download it from the site. So it can be calculated to estimate women cardiac risk during pregnancy. Despite dramatic improvements in survival and quality of life for patients with severe congenital heart disease, other heart disorders, pregnancy is not advisable in certain high-risk conditions. The contraindications for pregnancy, everyone should know. Pulmonary arterial hypertension, if the arterial systolic pressure is more than 25 millimeters of mercury caused by any condition, including Eisenmenger. Severe systemic ventricular dysfunction, where ejection fraction is less than 30%. Coarctation of the aorta if uncorrected or if accompanied by an aneurysm. Severe aortic dilation, aortic root diameter of more than 45 millimeters in Marfan, other HTAD, bicuspid aortic wall ascending diameter of more than 50 mm, and Turner syndrome AAC of more than 25 millimeters and TOF more than 50 millimeters. Severe symptomatic aortic stenosis and severe mitral stenosis. A single ventricle and impaired systolic function, whether treated with Fontan procedure or not. Any Fontan circulation with any complications, vascular elegance, previous peripartum cardiomyopathy with any residual left ventricular dysfunction with ejection fraction less than 30%. So treatment of heart disease in pregnancy, 3 and 4, before they conceive, they should be treated medically and surgically. If they conceive, they should be offered early therapeutic abortion. Cardiac glycosodes can be used in pregnancy. ACE inhibitors, ARBs are contraindicated. Aldosterone antagonists should be avoided. Other treatment for heart failure like non-thiazide diuretics, nitrates, inotropes can be given. So key points, it's the final slide. Key points, pregnancy may not be advisable for women with certain high-risk heart disorders. Optimization of cardiac status and corrective cardiac surgery before pregnancy to reduce the incidence of morbidity and mortality. Have low threshold for even mild symptoms in pregnancy to investigate and do the ECG and get cardiologist opinion and echo. Multidisciplinary team approach and regular follow-up. Treat heart failure arrhythmias during pregnancy as for non-pregnant women. Treat most pregnant patients for atrial fibrillation with standard or low molecular weight heparin. Endocarditis prophylaxis is not needed for deliveries. But for structural heart disorders, it is the same as for other patients. To avoid ergomethrin, prostaglandin, ritodin, salbutamol, high-dose intosinon, and monopolar diathermy in pacemaker and mechanical valves. Thank you.
Thank you, Dr. Sumati, for the elaborate presentation. And it's a question for regarding, can you elaborate on or can you tell what is spontan circulation?
The Fontaines is when there is a single ventricle that is bypassing the venous circulation, bypassing the ventricle and bypassing the venous circulation to the pulmonary circulation, bypassing the ventricle. So it's called Fontaines procedure. So in case of the blood flow will be from IV venous circulation to pulmonary circulation. The ventricle is not needed. That is the bypassing the circulation to the pulmonary this thing. So this is done in single ventricle. I think cardiologists, our sir, should be able to explain it more clearly. Fontaines procedure. That's what I know about Fontaines procedure. That is not advisable for pregnancy because they have mixing of blood will be there. There will be so much of cyanosis and peripheral hypoxia will be there. Fontaines.
Okay.
Thank you, madam. It's my privilege to invite the next speaker to speak about the first of its kind state registry, Tamil Nadu Pregnancy Heart Registry, which was initiated keeping in mind the increasing contribution of heart disease complicating pregnancy to maternal mortality. We all know that it was the brainchild of Professor Justin Paul, who's the State Nodal Officer, Heart Disease Management Program, Tamil Nadu. He's a member of Board of Studies, Super Specialty Courses, MGR Medical University, and also School of Philosophy, Madras University. And of course, he's developed interventional cardiology in Government Stanley Hospital, Omandurar Multi-Specialty Hospital. And he's the principal investigator for TNPHDR, and of which we are also proud members, co-investigators. Thank you, sir. Over to you.
Thank you, madam. Thank you for the nice words you have shared. 1 second, let me just share my slides. I thank the organizers for giving me the privilege of sharing some of a topic that is very close to my heart, something that I really want to do something about in the society. Thank you for the privilege. Thank you for the opportunity. The topic that was assigned to me was registry of heart disease and pregnancies. Now let us see what really happens here. If you look at the maternal deaths per 1,000 in the world, this is what is happening. From 450,000 women dying per year. What is really happening in India? From 103,000 dying per year, we have come down to almost 35,000 dying per year in 15 years. That's a great achievement. But is that sufficient as of now? If you look at the absolute numbers of mothers dying in the world, right now we are second. But we also need to understand our population. Our population is very high. But a country like China, which has an equivalent population, has a much lower death than what we have. So we need to get into that part of it. So this is the actual maternal mortality that we have achieved. And we really need to work hard in this particular area, not to say that we have not achieved much. We have done a great job as of now, but we really need to work hard even now. Now, if you look at what we have done in this world, from 1.2 million mothers dying per year, we have come down to 300,000 mothers dying per year. This is the world average. Now let us imagine if the entire world is like Scandinavian countries or European Union, we would have got only 11,000 mothers dying. So if we provide a proper care across the world, we can save almost 290 mothers from dying every year. That's a very, very huge number. What about India? So the Sustainable Development Goal for India to reduce the maternal mortality is 70, and we are yet to achieve for the country. Though Tamil Nadu, we are proud to say that we have achieved it. As a nation, we are lagging behind. So we are still in the obstetric transition stage 3. You will be familiar with the obstetric transition stages created by Sousa. In 2014, he coined the term, how the MMR comes down so that the strategies for improvement in various levels need to vary. In fact, in the country of India, only Kerala is in obstetric transition 4 with an MMR less than 50. In Tamil Nadu, we are trying to venture into stage 4 from stage 3, whereas many other states, particularly the Bimaru states, are the where the more empowered actions group states, they are still in the lower end of stage 3, or some of them even stage 2. So what about, this is what I was talking to you about, what we have achieved over the period of time in Tamil Nadu. So now, shifting gears, we'll see what are the causes of maternal deaths in a developed country like UK or a developed country like United States. Almost 15 to 20% all mothers who die during pregnancy are due to heart disease. So certain, in fact, in UK, in 1 year, it was 26% of mothers who died due to pregnancy-related cause was due to heart disease. So as the nation improves, if you further want to reduce the maternal mortality, we need to concentrate on heart disease, because this is going to be the leading cause of death. Like, as obstetricians, you do a great job in taking care of the bleeding complications, the infective complications, which were the predominant chunk of cause of maternal deaths. Because of your great, wonderful role, you have brought them down now, and you have brought us into the forefront now. So that we need to work hard with you. We both need to work together with each other to develop in this field of cardio obstetrics, where you can work together to improve the cardiac deaths during pregnancy. So this was in a large analysis published a couple of months back, which in fact published in 2018, but it was updated in 2021. See, as you can find, of the 237 maternal related deaths, 14% were due to heart disease. And the story they found was majority of these deaths were preventable. Majorities of these deaths were preventable. That was quite, sad that, we couldn't do that. 1 second. Yeah. Now, this is another information. What you find, this is another analysis from 9 counties or 9 states in the United States. What they found was 2/3 of all heart disease related deaths could have been prevented. Imagine the numbers. 2/3 of all deaths in a nation like United States could have been preventable. They're able to report this because they are doing an auditing system. They are evaluating that. Now look at the Tamil Nadu mothers' deaths. This was the data I was able to get sitting with our obstetricians and the team of NHM. So what we found was, as say from 2011 to 2020, the share of heart diseases causing deaths have increased from 4% to almost 10% now. I'm sure this is likely to increase to 15% as obstetricians are working hard to improve the obstetric and the non-cardiac causes of death. So our role is going to become much, much larger in the days to come. Now, all of you are very familiar with this story, Alice in Wonderland. This poor little girl falls into this rabbit hole and she doesn't know where she stands and she doesn't know where to go. Now she's asking this rabbit, which road do I take? Well, that depends on where you're going. She says, I don't know. Then it doesn't matter. If you do not know where you are going, any road will take you there. That was the answer, the wonderful answer the rabbit gave. Now, we are not like Alice. We know where we are going. We know that we are targeting towards a low maternal mortality to prevent cardiac death. The only issue is we do not know where we stand. What is the reality of the deaths happening, cardiac deaths happening? What is the kind of care that is being given at this point of time? Is it all appropriate? That initial part of it, we are better than Alice. That part, we are equal to her. We do not know where we really stand. So we want to achieve this kind of maternal mortality, a rate of 5 to MMR of 5 to 8. So now you're all we know that science tells us what can be done. Guidelines tell us what should be done. It is the registries that tell us what is being done. And unless we know what is being done, how can we plan our strategies to take us from where we are to take us to where we want to go? So that is the need for registries to be developed, because they really tell us what is being done. Now, how do we get the data? Now, I think a lot of you talked about the guidelines. The 2018 European Society of Cardiology guidelines is a very widely quoted. In fact, the British Journal of Obstetrics and Gynecology, they just quote verbatim from this thing. They use this guidelines, and this is the guidelines followed throughout the world. We need to understand that how these guidelines are generated. Now, there are 3 large studies. The Zahara study, which was done from Belgium. You can look at the very small nation of Belgium, and over a period of 27 years, it was a retrospective data collected from the online soft copy of the case records. Based on that, they have given a lot of guidelines, including the Zahara score. And then we had the CarePreg 1 score. And the CarePreg 1 was there. CarePreg 2 was published after the guidelines was published. And the CarePreg 2 and 1 were from 2 Canadian hospitals of 1900 pregnancies. And now this ROPAC study, this is the largest study in the world as of now. The registry, largest registry in the world, 5,700 patients, was published in 2019 years in the European Heart Journal. This is a study from 55 nations. So now these are the guidelines that are used to tell us what to do. And so we apply data from Belgium and Canada to the population of Tamil Nadu, Kerala, West Bengal, Bihar, and all these places, and we try to implement them. Now, what about data from India? It's not that we don't have data. These are some of the studies that have been published from India. As you can see, I could have missed out a couple of them. I did a thorough search. All these red dotted ones are retrospective studies and case records. From the south, you can see we have done more prospective studies. In fact, from Tamil Nadu, you can see a very large prospective study from Trichy, the 129 rheumatic heart disease patients. And from JIPMER is the largest rheumatic heart disease study in India, 681 patients. And this was the background. And European Heart Society, they recommended that registries to be started. In fact, even before the guidelines came in 2018, we started the MPAC registry, the Madras Medical College Pregnancy and Cardiac Registry, presently the largest database in the country. So I should really thank all these people. Some of them I have missed out. In fact, I would have troubled all of them at odd times to, move on with the vision of getting this registry data. Thank all the obstetricians of KGH and IOG who partnered with this, and my fellow cardiologists who we worked hard to get this data. Now, this is presented in the European Society of Cardiology 2 weeks back, and this is yet to be sent for publication. We are just writing it up. Now, as you can see, in 1,005 women, we had 1,029 pregnancies. You find that almost 60% of them had their diagnosis known during the pregnancy. They were diagnosed to have heart disease only during the pregnancy. Some of them could have been that the patient knew, but the spouse did not know. All these kind of stuff, so you're all very familiar with. Now, looking at the MWHO categories, which some of you alluded to, we have representation from all the categories. And majority of our patients in MMC, MPAC were asymptomatic. And this is the spread of our acquired heart disease. Rheumatic heart disease formed the chunk of the data. Why I present this thing? This is the data from which we need to base our guidelines, how we need to treat our patients, not really from the CarePreg and the Zahara, which was done from the best of the institutions with the best of the facilities available. Now, this is the data of congenital heart disease. We have 346 patients with congenital heart disease. We also studied a small sub-study from these, which I'll share to you later. The largest group were septal defects. If you find that complex cyanotic heart diseases, they are much less in this public hospital, because many of them, they do not make it to the adulthood, or they do not survive to pregnancy. So if you look at the developed countries, this group will become larger too. Now, as our cardiac management, pediatric cardiac management improves, we are likely to see more and more of these patients who need more and more of our coordinated cardio-obstetric care. Now, if you look at that, large number of them had a prior cardiac procedures, almost 211 of them. And these were the surgeries done in our patients. And surprisingly, if you find that only 39% of our patients had cesarean section. In the same time, those without heart disease, 48% had cesarean section. So heart disease, in fact, was encouraging the obstetricians to go for a cesarean, to go for a normal vaginal delivery than a cesarean section. It is true that many heart diseases, they do not really need a cesarean section. If you look at the maternal cardiac events, 158 patients out of these 1,029 had cardiac events. We started identifying what are the risk factors for cardiac events. 20 of these mothers died. So we lost 20 mothers, and I was involved personally in at least 13 or 14 of these mothers who died. And 103 patients had heart failure. If you look at prosthetic valve thrombosis, 13 were there in prosthetic valve thrombosis here. In fact, we started following these patients quite some time, but we were able to come out with a form of a registry database from July 2016. And these were the various causes of death. 6 causes of deaths were related to prosthetic valve and not really thrombosis. Some of them were related to bleeding related to the prosthetic valve thrombosis. And we had heart failure and pulmonary hypertension causing deaths. So if you look at the fetal outcome, large...
Excuse me, sir. You have got 3 more minutes, sir.
How many minutes left, madam?
3 more minutes.
Yeah, I'll try to finish up fast. Yeah. Okay. So these were the predictors of adverse outcome. As you can find, the patients who had a worse WHA class, LV dysfunction, those who had a mechanical prosthetic valve, they had a very bad cardiac outcome. And the same way WHO categories as well. If you look at the predictors of maternal outcome, these were the multivariate predictors of maternal outcome. And NOHA class and LV dysfunction are significantly associated with maternal death. So we found that certain areas where we need to work together, the cardio-obstetric team, the preconception counseling, and the transitioning of care from adolescent school health to the adulthood, they all really will help in reducing the cardiac output. And we presented some of these data in this, in fact, it's going to be published next month in the October issue. We found that in the congenital heart disease group, only very few of them receive a true premarital preconception counseling. And obstetricians and cardiologists were equally involved in the counseling, but those who developed counseling. If you look at the appropriateness of counseling, we really need to improve the appropriateness of the counseling, because those who are giving counseling, we also have need to improve on what we talk to the patients, understanding the disease process. So what we found was maternal cardiac events were less and live births were more in congenital heart disease patients who got a preconception counseling. And very high-risk patients who require a contraception did not really get the appropriate contraception. So then we start with TNPSTR registry, where most of you are involved in this thing. In fact, our family is very large. This is the data that we have collected, 2,800 patients. Now, this is the largest database in the country, Asia, and the second largest database in the world. We are collecting data. I thank all the investigators who are here, who are collecting the data on this thing. This is a preliminary evaluation. These are the type of the patients that we have. This is the age group of the patients we have. And we find that less number of patients were delivered by vaginal delivery. This is the outcome. We are working on that. Now, coming to the crucial areas where why registries are important. This was the latest update. I will take only 1 minute or 1.5 minutes more.
Okay, sir.
Steps for improving the care. This is very important. We need to understand the disease spectrum that we are understanding and developing a pregnancy and heart disease team. In fact, we should be thankful to the Tamil Nadu government, which really, when we requested, they formed an order that all the government medical colleges should participate in this registry and should form a pregnancy and heart team. This is the core. In fact, we are working together. We are a part of it. The development of cardio obstetrics is a field is very important. We need to develop that. and improving the research and registry data. Now, this is where we are at this point of time. And with the evidence base, then we look at the training and education, which we're already starting looking at. This is how we need to move forward to reduce the heart disease adverse outcome in this. In fact, we talk about Make in India. So we have to develop our data, we have to develop our guidelines, and we have to apply these guidelines and empower our team. So to take home points, this will be my last slide. We improve the awareness of the need of pregnancy and heart team in every hospital. We need to develop the field of cardio obstetrics. We need to develop a curriculum for the field of cardio obstetrics. We need interested faculty in this field. We have to make sure that we avoid unplanned pregnancies by improving counseling and interlinking of the school health programs and the adult women health programs so that we can give the care appropriately. We have to train the healthcare provider to understand the disease and provide a patient-specific and a person-specific counseling. We have a lot of patient and family-related issues, domestic violence issues in these women. We need to, in fact, work on supporting them. We have to generate our own data and guidelines, Make in India, and empower the system to offer the best coordinated care to these patients and reduce the maternal mortality contribution from the heart disease. Thank you very much from the Impact team and from the TNPHCR family. Thank you very much. Thank you.
Thank you, sir. Thank you very much.
Thank you, sir.
Thank you, sir.
It was an eye-opening thing because we need to develop registries not only in heart disease and all medical disorders complicating pregnancy. Thank you very much, sir.
It was a very interesting talk, and hope we develop our own guidelines for managing our pregnant heart disease patients. Sir. Thank you very much.
Sir, Paul, sir, good evening. This is Sampath Kumari.
Good evening, madam.
You have mentioned about the importance of registry. Sir, you are doing this, no? Is there any difference with the heart disease mortality in pregnancy before the registry and during the registry?
It is too premature to say that, madam. But one personal cases wise, I can tell you, during the registry formation, we find that there's a more coordinated discussion and more appropriate care provided to the patients. Like we find that everywhere there's a cardio obstetric team and they discuss in the social media, in WhatsApp group, and they talk with each other, they network with each other. So getting a cardiologist opinion is more easy for obstetrician now, and getting an obstetrician consultation is more easy now. As a result, there is a transmission of information on either side. I can definitely say, for example, a patient was shifted for antenatal balloon mitral valvotomy, and we did a balloon mitral valvotomy at Madras Medical College. Then the patient to Coimbatore, the patient had a safe delivery. These are some of the kind of networks. I'm sure the personal anecdotal improvements, lot of cases I can mention, but evidence, data collection wise, it is too premature to say, madam.
Sir, have you stressed that echo is must for all antenatal patients to the government?
It is not a must in any of the official published guidelines by any official cardiac or obstetric society, because it is going to tax the system too much. It calls, in fact, there are stethoscopes that have come that can pick up the murmurs very easily for the obstetrician in the clinical practice. And in fact, ultrasonic training for obstetricians to identify ice-pick view of heart and how are sonologists to find out is there any heart disease. These are all more easier because when the patient goes for an obstetric scan, the obstetrician can just put the probe also on the heart. And if there is some doubt, they can send for an echo. These are some of the ways of appropriately using the technology. But in a country like India, where you can hire an echo technician for 10,000 to 15,000 rupees per month, it is not going to be difficult. But framing a guidelines like this is going to be very expensive in a country like US, where an echo costs about 20,000 Indian rupees in US minimum.
But in our place itself, corporation is doing echo for all, sir. But in a places like our main Institute of KGH and IOG, in that OP, Monday OP, it will be difficult to pick up the murmurs stethoscope. So you can inform the government to make echo as compulsory, sir. with this registry. This is my
Madam, I will
request.
tell you, it's at the point, I do agree that, it is good. But at the same time, what I'll tell you is, when we register 330 new patients in the cardiology OP at Rajiv Gandhi Governmental Hospital, 150 are antenatal mothers. Now, these antenatal mothers can be, they can have an echo by hiring an echo technician at your institution for 15,000 rupees per month, so that we can appropriately concentrate on the high-risk patients. So when you load the system, the efficiency of the system will come down. So that is the reason why I say that, you can make it echo compulsory, but then you have to make appropriate facilities and infrastructure to get an echo done. You cannot burden the overload existing.
If you don't mind, I will give one suggestion. One of your first year PG can go to OPs daily, at least for 11 o'clock to 12 o'clock. In that time, if it is possible, I am telling. I am retired from government, so I am telling all ideas. Okay, sir. Thank you so much.
Thank you for your ideas. Thank you for your ideas.
Yes, Sumati.
See, as Sir said, as I emphasized in my talk, very important pre-pregnancy counseling, pre-marital and check the heart and at that situation itself, find out the thing. And in the during pregnancy, first visit itself, all of us should take the stethoscope, not for consultants. All the PGs and junior doctors can easily auscultate the heart. If you hear any murmur, it can be small mid-systolic murmur, whatever it is. If you find any abnormal murmur, is just referred to the cardiologist after taking the ECG. I think that way, as Sir said,
Sumati, I will accept your point. But one day OP, you come and see the IOG, Institute of Obstetrics and Gynecology.
Definitely, I agree.
It will be very, very difficult to see.
Very difficult.
We are diverting away from the topic that we are discussing. This is an administrative topic that needs to be discussed within the institution, not in this TNFOG talk.
None of the society endorse routine but many a times for medical legal purpose, I used to wonder, because many a times patients coming with complaints of vague breathlessness come to us. At least we should make sure that one echo for a patient who is complaining we have to do, because like peripartum cardiomyopathy we never thought earlier. Now we are seeing, and many times if we are going to encounter such a patient, it's doom. The patients will come back and tell, why didn't you do a actually the panel I have put a question for all the.
That's why we should have low threshold. Low threshold.
Empowered to
Very
do
important
the
in pregnancy.
Because in corporation, after a maternal death on the theatre, they have analyzed, and for the past almost 10 years, they are doing mandatory for all low risk pregnancy.
Madam, as I told, this is an administration problem.
Where we have any time approached to the cardiologist, we are not insisting. In a corporation where their resources are low, they try to be protect the
Any patient with a symptom,
Cardiologists are coming to both the institute. They come weekly once. They are doing their best. Thank you, sir.
What we'll do is, any patient with the symptoms, echo is a must. Any patient without symptoms, it is the discretion of the obstetrician. So you make sure that if you have doubts, clear it off.
Always put probing questions like, whether you have any palpitation or chest pain, all those things in each visit. Just take a few seconds to ask them, all the pregnant ladies. Maybe in my setup, I cannot compare with the institute, but still you can ask 2 questions each visit. Any
we can do it.
Chest pain, all those things can be asked. So probing question is very, very important. Some people will not tell, if you ask another customer come up, you have to ask them. Probing questions are very, very
Also,
important.
like cardiology cases from TNFOG, we are trying to make registry for eclampsia, PAH case, anemia case. So only I asked you to stress about the registry. You have done your job fantastically. That we will also do it. Thank you, sir.
Thank you, sir.
I am Anita. Chitrakala, you can go for question. The first session winner is Dr. Rajalakshmi from Thuthukudi. Rajalakshmi Kandasamy.
Vanita, a lot of disturbance from your side, Vanita.
Yeah. Chitrakala, you can post the second session question. Endocarditis prophylaxis is indicated in vaginal delivery,
We now move on to the panel on introduction.
One of the system is having some noise. So somebody is doing mute all every time the noise is coming. So it will be better if that system identifies themselves and switch them off. Thank you.
yes, Vanita.
Yes,
Vanita, you have to mute.
Madam, the problem is in Vanita's system only, madam.
Vijayalakshmi, you start introducing. Vijayalakshmi Gnanasekharan, madam.
Vanita, can you mute, please?
Yeah.
Okay. I'm very, very happy to introduce this panel. It is going to be moderated by one of the great academician whom we are having, Dr. R. Premalata. Madam is consultant and head of the department of Mehta's Hospital, Chennai, and she is presently the incoming, she is the vice president of FOGSI. We are very happy to have you, madam. Next, can I have the next slide, please? And as our panelists, we have a distinguished panelist, Dr. Deepa Tangamani. She is joint secretary of ATN RCOG, member of all the boards like OGSI, ATN RCOG, IMS, CMS, IH, ISOPARB, etc. And past member representative of AICC RCOG. And she is very good academician, always there for quiz and other things. And we are happy to have you, Deepa. Dr. M. Vijayalakshmi. She is a graduate from Tirunelveli Medical College, lab trained with Dr. Kurian Joseph, an MD from Madras Medical College, and she is interested in infertility and high-risk pregnancy. And thank you, Dr. Vijay. Next, we have Dr. Sumati. Madam is professor and Department of OBG at ISO KGH. She has 30 years of experience in government service, and her areas of interest are cancer screening and social obstetrics. Thank you, Sumati, madam. Next, we have Dr. Tennarasi, senior assistant professor of Government Rajaji Hospital, Madurai. She is an UG of Tirunelveli and PG of KMC. She is presently from Madurai Medical. She is representing Madurai Society. Thank you, Tennarasi. Next. And we have Aarti Darga. Madam is there with us and all. She is one of our executive members of TNFOG. And she is an MBBS from Baroda, lab trained person who is presently a consultant at Vijaya Nursing Home, Sivakasi. And she is secretary of the Virdhanagar West Obstetric and Gynec Society, an EC member of TNFOG. Happy to have you, Dr. Aarti. I think, yeah. Dr. Anita Thamari Chelvi, associate professor of OG Government Dharmapuri Medical College, special interest in high-risk obstetrics. Thank you all panelists. Now the floor is yours, Premalata madam. Please take over. Ma'am, please unmute yourself and you can start. Yes, ma'am.
Okay, I think. Thank you. Doubts. Am I audible now? Am I audible?
Yes, ma'am. Yes, ma'am.
Okay.
Yes, ma'am.
At the outset,
You're audible. You can see the screen also.
Thank you, Dr. Anjalakshmi Madam, Dr. Sambat, and all the TNFOG members for giving me this wonderful opportunity. We are at least lagging behind time for more than 30 minutes. So I just thank everybody, and I have a galaxy of my eminent panelists. And going through hearing all the topics earlier, lectures by previous speakers, I think my topic is going to be very, what is that? CC, because I'm going to just throw questions upon it, and everything has been already discussed detailedly. So I'll start with my panel. We all know that's already told that cardiovascular disease in pregnant women varies between 0.3 to 3.5%, one of the non-obstetrical cause of maternal death. And we have already heard repeatedly, it is a spectrum of disease has changed from it is increasing towards congenital heart disease, and the rheumatic heart disease nowadays come in a better, good functional state because of the better standard of living, better antibiotic prophylaxis, and better diagnostic facilities. So as a result, pregnancy has become a realistic option for many of these young women. These cardiovascular disease account for significant maternal morbidity. So the physiological adaptation have made 1 minute. அம்மா நான் மீட்டிங்ல இருக்கேம்மா, என்னம்மா வரலையா? வச்சிருங்க. So the physiological adaptation of normal pregnancy has a lot of changes which confound the diagnosis of heart disease. The physiological changes, I'm not going to talk repeatedly, it has been told by all the speakers. And now going to the case history. Mrs. P, 20 years old, a primary, a domestic help, has reported at 24 weeks of gestation with the onset of dyspnea on medium exertion for the past 5 months. It was relieved by rest. The past 1 week, she is complaining of dry cough at night with dyspnea. She gives history of vague treatment at the age of 8 years for a year or so for heart problem. And I'll just come with Sister Deepa Kankamani. Do you consider she has cardiac problem? Clinically, how do you assess her?
Okay, she had dyspnea at night with a dry cough and dyspnea and exertions. Yes, of course, cardiac is my first diagnosis. We have to rule out other causes like respiratory causes and anemia, which causes easy fatigability, and respiratory causes like asthma. We have to roll out. And since the history of 8 years, some history of vague treatment, maybe rheumatic heart disease prophylaxis. I really don't know. Probably, my first diagnosis will be the cardiac problem.
Okay, actually, this is a patient who has not taken any proper treatment, but with the clue that she had some cardiac problem and now she's having breathlessness, we have to think it may be a first time a cardiac disease which has been unmasked by pregnancy because of thing. So on examination, I'm giving, she's comfortable at rest, no pallor, bilateral mild pedal edema was present, JVP was not elevated. She has a tachycardia of 100 per minute, pulse, blood pressure is 100 by 70, respiratory rate is 20 per minute. Lungs are clear and cardiac murmur is heard, and uterus is corresponding to 24 weeks. We all know the normal pregnancy, these changes can be there. Dr. Vijay Lakshmi, can you, just we know that it is a normal pregnancy, also the same symptomatology can be there. What are the cardiac indicators, clinical indicators, which will say this is a case of heart disease, and how will you diagnose in this patient? What are the clinical indicators you are going to look? Already it has been discussed.
She is having paroxysmal nocturnal dyspnea, orthopnea, orthopnea, she is having cough, symptomatic cough. And if we can auscultate the patient, there is any diastolic murmur, systolic murmur grade greater than 3, you can diagnose.
So, Dr. Sumati, this patient had a murmur, and how do you just, she has a symptomatology of progressive dyspnea, nocturnal cough, and she has a murmur in the thing. So, how do you arrive at the diagnosis? What are the investigation? How will you proceed in this?
So now that we are suspecting that she's having a heart disease and she has got symptoms of dyspnea, and on auscultation, if you have a diastolic murmur, we'll go about with certain investigations like ECG and echocardiogram to find out what is the valve, if there is any valvular lesion. Clinically itself, we can diagnose. If we are having a diastolic murmur, we can diagnose whether it's a mitral stenosis. We can make a pulmonary hypertension clinically itself. And if you are going to have a murmur or a thrill in the palpation, that all will indicate that she's having a heart disease. We'll confirm by doing a ECG and echocardiogram. Echocardiogram will tell what is the valve involved, the most common being the mitral valve. We can find out the mitral valve orifice. We can also find out the ejection fraction. If she's going to have a heart disease or previous history of heart, we can just measure, find out if there is any thrombus in the mitral valve also. And we can also find out if there is any pulmonary hypertension associated with this. All these things will tell that she is having a heart disease, and echo is mandatory in doing this.
Okay, as Dr. Sumati has told, echo is a very important diagnostic modality in order to diagnose heart disease. Not only to diagnose, to know whether she's having a left ventricular dysfunction, pulmonary hypertension, the area of the mitral valve, and the thickening, or all this will be known by this. On examination, she was actually basic investigations were found to be normal. She was diagnosed as a case of mitral stenosis with thickened and calcified valves. Mitral valve area was 1.5 square centimeter. The ejection fraction 60%, the trivial mitral regurgitation. So this patient, once diagnosed, how do you categorize the risk of heart disease in this particular patient? What is the various, actually previous speakers were talking about the various categories of risk classification. So Dr. Tennarisi, what do you think? How do you categorize her in this particular patient? What category she belongs to, like function capacitor?
She belongs to class 2 NIHA, ma'am.
So by NIHA classification, it is more like a stage, I mean,
class 2. Class 2.
But what I was thinking, because she was complaining of nocturnal dyspnea and cough, whether from 2 she's maybe going for
maybe
3.
So
that's the thing with it. So what are the pitfalls in this, mainly putting as a NIHA classification? Are we going to have any other classification to regarding this cardiac risk? Cardiac disease risk stratification, any other risk stratification you are wanting to think about it, not in this particular patient, in general in a cardiac disease?
We have got the WHO risk classification, madam. It gives us a high risk, intermediate risk, and mild risk. So mild risk, we can have this mitral valve prolapse, mitral regurgitation, pulmonary stenosis, repaired heart disease without any residual cardiac dysfunction. In my intermediate risk category, we have large left-right shunts, repaired lesions with residual shunts. We can have mitral stenosis, we have aortic stenosis. All these things comes under, and prosthetic valves too comes under intermediate risk category. And in very high risk category, we have got 4 things, and they are the NIHA class 3 and 4. They come under high risk. We have got morphins with a significant aortic root valve dilatation more than 4 centimeters. We have got severe symptomatic aortic stenosis and significant pulmonary hypertension. This forms the high risk category under WHO risk classification.
So as you have explained clearly, WHO risk model mainly tells us what is the mortality risk or what is the risk for the mother in relation to the structural heart disease. Whereas NIHA says mainly a functional activity, and we are not, this says a WHO model 1 says very lesser, I mean, a risk not higher than the general population, whereas a WHO 2, it comes as a small increase in risk of mortality. And I would like to actually tell, previously we used to have this risk, maternal mortality risk. Very early we used to, when we are students, we used to read about the maternal mortality risk in relation to the structural anomaly. Less than 1%, 5 to 15% mortality is 25%, 50%. Depends upon, it is more or less correlating with the WHO role model. Anybody want to tell about corporate risk score? Does it help us, or do we try to find out corporate risk in our routine thing? Dr. Deepa, do you think corporate should be looked into?
Corporate is like a pointing systems, like if you have a sick heart failure, arrhythmia, they can any of these 4 scoring systems, like ejection fraction less than 40, or your left heart obstruction, if a valve disease less than 1.5 centimeters pre-pregnancy. So it is mainly tells us whichever the point we'll have. If you have 2 or more than 1 point itself, which comes around 1 or more than per point itself, 75% risk of adverse cardiac event happening in the pregnancy. So this our lady which is having a left heart obstruction with a mitral valve less than 1.5 is hello. So corporate is like the same thing.
So actually corporate
it gives importance to the previous history of failure. One thing important about corporate is what is the history of previous cardiac events she had. That is very important in determining the progress of the patient, whether she'll go for failure this time also. The important thing about CORPREG is previous history of cardiac events.
CORPREG is a predictor of adverse cardiac event, and it is mainly a pre-pregnancy history taking, where we have a pre-pregnancy arrhythmia, pre-pregnancy endocarditis, pre-pregnancy cardiac intervention, all be taken into consideration. Like a flowchart, if you see the pre-pregnancy events, and we can have physical examination, whether cyanotic, all this will. And this is mainly useful for assessment of risk assessment and pre-pregnancy counseling. With all this, actually, this woman has diagnosed as a case of mitral stenosis with a mitral area of 1.5 square centimeter, ejection fraction 60%, and she's having dyspnea at 24 weeks of gestation. What do you advise? How will you classify? We have told it's a NIHA class 2. Do you advise hospitalization? Dr. Tennarasi? Then the next one is Anita. Okay. Who are taking?
Now she is having dyspnea on exertion. Now, usually we don't since she's symptomatic.
Can't hear, ma.
She's symptomatic, ma'am. So we'll admit her and we'll assess her severity. We'll get a cardiologist opinion and we'll start her on diuretics, digoxin, and therapy will start.
So once the patient is symptomatic, whether it's a NIHA class 2 or 3, we may have to admit her, hospitalize her, stabilize her. We have to see it should be a team approach with an obstetrician and a gynecologist, with a cardiologist. She had furosemide and she had a metoprolol and oral penicillin. She was 20 years she had been given. She was looked for anemia, no respiratory infection. We have to treat for any factors which are the aggressive factors for her dyspnea, actually. And this what will be her influence? How will you counsel her? What is her plan of management regarding her fetal surveillance and her mental? How often you like to see, or you want to keep her for a long time in the hospital? Dr. Sumati? Sumati, you are in Gosha. Such a patient comes to you, do you discharge her? How often you want to see her? Sumati is not there. Dr. Deepa?
Yeah, this is, see, as you said, madam, I usually admit her first diagnosis, class 2 to class 3, she comes under. I will put a cardiologist involvement and then improve her functional status. Once I improve her functional status, well, discharge her, but we'll keep her review every 2 weeks till she goes up to 32 weeks. When the demand comes, the cardiac peak demand comes, probably I'll review her again at 32 weeks, and afterwards, if she's functionally better, probably I will see her every week, or I will admit her around 32 to 33 weeks. So fetal surveillance as a routine, because there is an exertional dyspnea, there will be a compromise of uteroplacental insufficiency, looking for the fetal growth from 28 weeks and 32 weeks, and including a Doppler. She need to be monitored. Mothers, all signs of infections, we have to avoid anemia. She has to take maximum rest at homes. If she couldn't be able to do it, probably she will admit.
This was a patient who is a domestic help. So that's why I was trying to find out whether you'll admit her for a long time or you just advise what we do.
Since we are putting her on diuretics, we have to monitor her volume also. Whether she is having, the baby is maybe affected by the diuretics, so we have to frequently monitor her hematocrit, fluid balance, and whether it is adequate or not, we have to do.
So every once in 15, actually this woman, she had improved her symptoms in a week time, but she was feeling very tired. And she was telling she could not be doing her normal activities. Is there any role for cardiac intervention now during this pregnancy for such a patient? What do you think about cardiac intervention during pregnancy? Dr. Anita?
If she is not responding to our treatment, we can go for a valvotomy, ma'am.
So, what are the indications? When do we do cardiac intervention in any pregnant women per se?
Pulmonary edema not responding to our treatment, severe mitral stenosis, that is less than 1.5 centimeter, and
actually this woman had a calcified valve and it was less 1.5 square centimeter. Ideally, speaking, she should have had a cardiac intervention correction prior to pregnancy. And during this, okay. So during pregnancy, it is actually unless otherwise symptomatic in spite of her treatment, we are not going to do it. Just for completion's sake, I would like to know for the cardiac intervention, what is the what is the period during pregnancy, if at all needed, what is the period of pregnancy you would like to do a cardiac intervention?
Second trimester.
So usually
during the second trimester.
Okay, Pam. And one of the associated complication in this case is not only pulmonary hypertension, atrial fibrillation can cause thromboembolism, and if it is persisting pulmonary hypertension, thromboembolism, atrial fibrillation, we may need a cardiac intervention. So this lady got discharged at 26 weeks of pregnancy, and she's seen in a joint clinic every 15 days. What is your plan of management? What do you advise? She's asking, when will I deliver? What is the time I have to deliver? How often? What is the plan? Will I have a normal delivery? She's having so many questions. And what is the obstetric management? What is your plan of management?
Madam?
Sumati?
Ma'am, we have to... Ma'am, we have to... Ma'am, we have to counsel the mother, ma'am, regarding the increased frequency of visits. What will be the progress of the disease, and what are the drugs she has to take regularly, and about the investigations and the possibility of growth restricted fetus, preterm labor, and hospital stay regarding the mode of delivery. And for every 2 weeks, she has to come and meet us.
So actually 26 weeks she got discharged, is coming every 15 days. Deepa was wanting to get readmitted around 32 weeks, but actually the plan of management was discussed to her. She came at, normally at 32 to 34 weeks, we should have a consultation with the cardiologist, and we should look for whether she's a apt candidate for vaginal delivery, whether she can have Alzheimer's manure. All this should be discussed, and we have to explain to her regarding the plan of management during delivery. The team should be aware of it.
Echo has to be repeated
delivery also has to be.
Yes.
And we have to rule for the valve orifice. We have to look for the valve orifice. We have to look for the, is there any associated pulmonary hypertension developed in the third trimester? And accordingly only then we can manage we can decide on the mode of delivery and timing of delivery.
So at 34 weeks, she has been seen by the cardiologist, and she has been found to be stable. And now she is, what is the role of induction of labor in such cases? Deepa, do you have a routine induction of labor?
No, but routine inductions probably we won't do. But I want this lady to be delivered in the morning time when everyone is available. Probably I may induce her. She may give an option of induction when the fetal maturity is happening around 36 to 38 weeks, if everything is favorable. Because I don't want her to come in a vaginal delivery labor at the late in the night when there is no help. So probably elective inductions I may offer in the counseling, and also I prefer inductions if she is happy. And cesarean deliveries, if she is really into failure, but since she is stable, probably we can give the option of elective induction.
Dr. Sumati is there? Sumati? I don't know, in the government setup. I don't know, she's not. No, I just wanted to know, because elective induction is a reasonable option, because previously when we were students, we never had thought of induction of labor. We should say a heart disease, they will go for preterm labor. We used, and many a time patients used to come in very late in with congestive cardiac failure. We used to see a lot of morbidity and mortality. Now, when the patient is regularly coming to the antenatal, it's a reasonable option, elective induction, so that it is attended by a scheduled experienced team, and she does not land up in a weekend or in the midnight with the pains whenever the junior doctor is there. So, but when you induce, we make sure that it's a favorable cervix and everybody are around, and cesarean delivery is only for obstetric indication. As Dr. Deepa told, if the patient is having hemodynamic instability with a cardiac consultation, the multidisciplinary team, we may be forced to take her for a C-section. Otherwise, the main problem is main thing is vaginal delivery is the preferred modality of treatment. So a study from, what is the drug of choice for induction of labor if you are going to do?
Polycatheter. First, I will go for a mechanical induction.
Actual studies from AIMS have given, oxytocin drip and found to be a safe procedure. And many studies they have used vaginal misoprostol and dinoprostol gels for induction labor in stable heart disease found to be safe.
Sumati, now you can talk.
Sumati, Yes, ma'am. Sumati, I was just talking about the role of induction of labor in a stable cardiac patient who is coming in a regular checkup. What is your idea in a government setup? What do we do?
Government setup, we do induce if necessary, ma'am. If there is a necessity for induction, we just do it. Electively, we don't induce just because we don't have people, because all the time we have people, 24/7, we have the team. So we don't electively induce just because of the want of personnel. But
So,
we do induce.
So it is
But if there is
the
an
availability
like
of the personnel who can tackle emergency at 10 should be there. If you don't have that, when everybody are around, that is an option for elective induction of labor. So I just wanted to bring it in a person. Somebody is sitting. I don't know. Anita Tamarichelvi, you are in Dharmaburi.
Yes, ma'am.
So in the night also you have all facilities. You may have all your intensive care specialists will be there and all the ICUs. So in such institution, they are not worried about the anytime admission. But if you are going to be a team where only in the morning everybody are around, it is a reliable option. So coming to this person, she got admitted at 34 weeks with PROM, rheumatic myoclonus. What are you going to do? How do you proceed? And how do you monitor her in labor? Role of endocarditis prophylaxis. Vijay Lakshmi? She's not there. Aarti?
Madam, Rajita, Aarti mute பண்ணுங்க.
Anita.
I'm
Vijayalakshmi ma'am.
Okay, you tell me.
Vijayalakshmi ma'am.
The patient has come with PROM and 34 weeks. She has a regular checkup so far with the cardiologist and stable. How do you monitor her in labor? How do you proceed?
I will do
Are you going to give any endocarditis prophylaxis?
Yeah, endocarditis prophylaxis I will give. I will do per vagina examination, find out the Bishop scoring. The patient is in early labor, I will give vaginal misoprostol tablet, and then I will monitor the labor with cardiotocogram. Okay. If she is progressing in labor, say Sindosunan drip with minimal fluid overload. Role of endocarditis, I will give the antibiotic. Yes, she is a case of PROM. I will give antibiotics.
Dr. Deepa, do you give endocarditis prophylaxis? We have heard so far the endocarditis prophylaxis.
Vaginal deliveries and cesarean sections nowadays, they are not asking for because there is no evidence of infections. But here the scenario probably premature rupture of membrane. I'll discuss with my team. If possible, I'll go with the endocarditis prophylaxis. And as well as regarding the labor inductions, PROM usually will wait. Normally, if she progresses, is fine, depending upon the favorability. And if she progresses into normal labors, I proceed with a normal labor. Routine normal intrapartum care for the patients will take care, like put the patient always in the sitting or left lateral recommend position, give her some kind of oxygenation if needed, fluid restriction to be done, and probably if at all oxytocin is needed, very, very minimal dose in high concentrations with the less fluid overload we can give. Less than 2 milliequivalents per liters we can we can give. And
1 minute, what is the high concentration? Would like to know how many units and how you are going to add if it is going to be.
Suppose normally we are putting it in a 5 units, 500 ml of normal saline or lingual lactate. We will put her into the 50 ml of infusion pump we can induce at the rate of 2 milliequivalents. The same things in a high concentration slowly we can give, not as a bolus. Okay. Bolus will come once the baby delivery comes. So now it is only a small unit, but in 50 ml infusion pump, we can inject at the rate of 2 milliequivalents per liter.
So with she was induced with the prostaglandin gel, and she responded well. Her second stage was cut short by an outward forceps. She delivered a 2.2 kg baby, and baby cried at birth. What is the role of epidural anesthesia? It has been told that routinely in all heart disease, it decreases anxiety, tension. So epidural should be given in all the Western literature. What do we do? What do we practice? In Apollo, what do we practice, Deepa?
Definitely, I will involve anesthetist. So I want to involve her the pain management. If they are not happy with that IM opiates, then probably epidural analgesia. I start for the vaginal deliveries, the pain, so that one anesthetist will be in my team management. So I'm happy that any mishap happens, forever it is to manage the baby mother, I need an anesthetist backup. So epidural analgesia. Second thing, it reduces a sympathetic blockade for the patient. So the stress of the second stage will be very, very less compared to normal pushing and normal pushing happening in the without epidural analgesias, where there is a high sympathetic drive will be there. So I prefer epidural analgesias for this patient.
Dr. Aarti, how do you manage the third stage?
Yeah, ma'am, to prevent sudden fluid overload, and methyl ergometrin and prostaglandin should not be given. Intramuscular oxytocin can be given, should be given, and we can give a slow drip of intravenous oxytocin also. It has to, we have to give it slow. Like in 500 ml, we can have 4 ampoules of oxytocin, and it can be given slow at 36 ml per hour. Yeah, and like third stage, we have to have a controlled cord traction, and like immediately after delivery, like we have to have a continuous monitoring. If there is a fall of like oxygen has to be given, and if to prevent pulmonary, this is a time when the fluid overload takes place.
Yeah.
The fluid from the uterus and
you would like to know, are you giving routinely intravenous furosemide bolus at the time after the delivery of the third stage of the placenta delivery? Anybody having that thing?
Yeah, because this patient, she is having severe mitral stenosis. If there is pulmonary edema, we can auscultate. If there are basal crepitations, then surely we should give. Otherwise, if there is no problem, there is no necessity, ma'am.
Okay. There are some people who just routinely in a heart disease after the delivery of the placenta, they just give an intravenous furosemide. I don't know, I should ask my cardiologist's opinion to know. So just I wanted to bring it to the thing because it's given, it can be given, may be needed to prevent. It is not for, I'm not asking for after development of pulmonary edema, before development of pulmonary edema, when a patient, that is the time the auto transfusion and the whole blood is shunting back to the heart. A dose of intravenous furosemide or an IM furosemide may help. That is the thing. Dr. Sumati, people were talking about subarachnoid bacterial endocarditis prophylaxis is not needed. And what in our setup, do we in India, they say some of the books says in our setup in India, antibiotic prophylaxis is given as a routine to all women with heart disease in pregnancy. Are we giving?
Yeah, we do give antibiotic prophylaxis for all patients, except for patients with ASD, which has been corrected. But almost all the patients who are having a rheumatic heart disease, valvular heart disease, we do give.
Okay. So with this patient has delivered, when do you plan to discharge her? And what is the contraceptive advice? Dr. Aarti Anita Tamare Chelvi.
Yes, ma'am. So she is more prone for failure even 4 to 5 days after the delivery. So we'll keep her for a week. And regarding the contraceptive advice, we will not put her on combined contraceptive. Of course, after delivery, we will not put her on combined contraceptive pills. IUCD can be inserted under aseptic precautions, ma'am.
Okay. So
and,
okay. So already this has been already discussed in the previous lectures also. This woman had a copper T insertion in 48 days. She went home all right after a week's time. Now going back to the second case, the same lady actually 26 years old. After 6 years, second grada, para 1, live 1, LCB 6 years, has missed a periods after removal of copper T, the nausea, vomiting. She gives history of a cardiac surgery 1 year back and she's on regular checkup and on warfarin anticoagulant. She's not willing to continue pregnancy as she's told her baby may be defective and she will have only cesarean if she's on medication. How do you counsel her? Dr. Deepa?
So she is just confirmed that pregnancy or how many weeks?
Just missed the periods, must be 6 weeks.
Okay.
She's in a dilemma because she's on warfarin therapy, the same lady whom we have treated last time. After 6 years, she has come with a valve replacement surgery. And
what valve she is having, we don't know. Okay, we don't know what valve she is having. Probably if she's on warfarin, probably mechanical valve mechanism. So we need to discuss about the risk and warfarins and its relative teratogenicity, and we can't see the full teratogenicity. It's like a combined discussion, proper counseling we have to do. Just this is if she really wanted to have a second baby, let her pregnant and she can continue the pregnancy. Or if she really worried about the teratogenicity, then probably we can opt for her, give her a termination pregnancy earlier, before 8 weeks rather than later.
So we have actually elaborately, the previous speakers have told everything about anticoagulation. This I don't want to go again with that. This woman was counseled well about the risk of teratogenicity, and she's very keen to have a baby, and she continued pregnancy. Actually, she was having she had warfarin, low molecular heparin, unfractionated heparin in the first 6 to 12 weeks, followed by warfarin, and she was discontinued. The protocol, which was actually was told was the protocol of anticoagulant therapy was followed up. Actually, low molecular heparin, we are actually, I think low molecular heparin is not advised in such a condition because we are not able to monitor the anti-A activity. It was on unfractionated heparin. So she was switched over to heparin at 36 weeks, and suddenly this patient had at 37 weeks got into labor. Sumati, what is your obstetric management? She had 1 week earlier unfractionated heparin and was well monitored by putting a prothrombin time, everything. And now she's in labor. She comes to labor pains. Previous one, normal delivery, 37 weeks comes into labor. Sumati is not there. Vijay Lakshmi, will you take this in?
Now when did she take her unfractionated heparin? 1 week.
36 weeks. From that, she has been shifted.
So now she's not in any
restarted on unfractionated heparin from 36 weeks onwards, and 1 week earlier she was stopped on warfarin.
Now there is now she's on warfarin. No,
it's heparin.
Now we can
After 1 week
on heparin only, so we can allow her for normal vaginal delivery. Already she has delivered vaginally, so we can assess the Bishop score and we can deliver her vaginally. But there is no need for, because we have to give endocarditis prophylaxis because she has mechanical valve. So endocarditis prophylaxis should be given. She can be allowed for vaginal delivery.
So one of the complications of warfarin therapy in the second and third trimester is there may be a chance of intracranial hemorrhage for the baby during the time of delivery. If it is given within 2 weeks of her, if the patient goes into labor within 2 weeks of warfarin administration. It has been 1 week since her stopped warfarin. So what do you think, Deepa?
Probably we can check her INR. If it is INR is not in favor, she's fully coagulated stage, we have to go take her for emergency LSES. It's a little 37 weeks borderline preterm, so fetal hemorrhage is common. If it is cesarean section, definitely in general anesthesia.
This woman was delivered by C-section and epidural, and she was a baby. So cesarean was recommended with warfarin administration within 2 weeks of delivery. And regarding regional, so when do we give epidural catheter? What should be the time frame between a epidural catheter and the heparin therapy?
So if it is an unfractionated heparin, we can stop heparin just 6 hours before planned C-section, ma'am. And it can be restarted 12 hours later. Suppose you have planned.
Okay. So if you have had a low molecular heparin just 10 to 12 hours before the last dose, or heparin 6 hours earlier, it can be given. GA, if you are going to give general anesthesia, you have to avoid drugs which cause tachycardia. So this already we have told everything about it. Now I just go back to the next thing, congenital heart disease. We all know the congenital heart disease incidence is very high, increasing because of the corrective cardiac surgery. And we know that the risk of inheriting congenital heart disease for the babies are there. And it is the risk of inheritance is quoted to be 3 to 5% compared to 1% risk in the general population. And AST has a risk of about 4 to 18% recurrence. The mother is having VST 6 to 10%, aortic stenosis 4 to 18%, AST 4 to 10%. So all these women should be offered a fetal echocardiogram during the second trimester to be carried out by an accredited pediatric fetal cardiologist. So coming to the case, a 20-year-old lady who is a known case of aortic stenosis has come with 6 weeks of pregnancy. She used to have chest pain and syncope whenever she's working hard. Her husband and family are not aware of her cardiac status. She didn't reveal at the time of marriage. How do you evaluate and counsel her? Role of MTP and role of corrective cardiac surgery. Dr. Sumati? Sumati is not there.
Ma'am, we have to evaluate echocardiography, ma'am, for her. Because if it is mild aortic stenosis, we can allow her to continue pregnancy. If it is severe aortic stenosis, then she might have to go for a MTP. Yeah, so echocardiography will help us to like come to the decision.
So if the echocardiography shows the aortic valve area less than 1.5 square meter or the pressure gradient is more than 100 millimeters of mercury, she has a very bad prognosis during pregnancy. And this lady, because already she is having complaint of syncopal attacks and chest pain because of the decrease in the cardiac and the coronary perfusion, she might have had this chest pain and syncope. So you have to counsel her and what is the role of MTP and what type of NTP you want to do for her? Like she's 6 weeks pregnancy?
Yeah, ma'am, MTP actually, because she's having syncope and chest pain also, it will lead to decrease in uteroplacental perfusion also. So there will be risk of like IUGR and everything. Tablets we can give for MTP, ma'am.
So after MTP, she had a corrective cardiac surgery and she continued, she was advised to become pregnant.
Yeah.
So what is your concern? I mean, everything has been discussed earlier. If it is a case of septal defect, ASD, VSD, each person can take one PDA. Dr. Anita, ASD, PSD. Are we worried?
They can have reversal. They can have reversal whenever they go for hypotension, ma'am. So we have to avoid spinal anesthesia and hypovolemia. We have to be careful about hemorrhagic complications. So there can be reversal.
So usually ASD is well tolerated, a small uncomplicated ASD. If it is large and corrected, a good prognosis. VSD, when it's a large defect, it may cause Dr. Tennarisi, what about PDA and Epstein anomaly?
PDA, it is tolerated, ma'am. Suppose if the size of the defect is more and development of pulmonary hypertension leading on to the reversal, right to left shunt, there comes the problem, and it is detrimental to the mother, ma'am.
So all these congenital heart disease where you have a left to right shunt and when the patient is having hypotension or systemic hyper, that is the time the problems may occur. And so otherwise they are well tolerated. So in Epstein anomaly also, in the absence of cyanosis, in the absence of heart failure and arrhythmia, usually they tolerate well. And one of the common cardiac disease which we see encountered now because of the phallus tetralogy which has been corrected. What is the outcome for mother and the fetus in the case of corrected cardiac disease, phallus tetralogy?
If they are asymptomatic, ma'am, it has got very good prognosis, ma'am. If they have no cyanosis, no cardiac failure after the surgery has been done, then the prognosis is good, ma'am, for the mother and the baby.
So if they say if you have a more of polycythemia, that the hematocrit is more, the pregnancy risk is almost nearing 100%. So it depends upon the hypoxemia and the polycythemia. So if you have a less polycythemia and hypoxia is less, so one of the conditions where the neonatal or the fetal wastage is more in a case of cyanotic heart disease. So with that, I just, and one of the thing I would like to ask Dr. Deepa, mitral valve prolapse is more common nowadays and women are aware of it and they are just worried about, I'm having MVP, I'm worried MVP. So they come and ask, I'm just worried. So what do you advise them if a person comes with you? Then
just give a positive reassurance, tell them this will be very normal in pregnancy. They will tolerate pregnancy very well. And if they are really symptomatic, I'll put them on beta blockers and endocarditis prophylaxis in labor as a routine, not for a mitral valve prolapse. We won't be giving any routine endocarditis prophylaxis.
So they say mitral valve prolapse with the regurgitation endocarditis prophylaxis can be here. In a VSD, when you have a large defect, you may. So in a complex congenital heart disease, there is a role for endocarditis prophylaxis. Coarctation of aorta, we don't see much, but time and again, people have told that for a coarctation aorta, that's a concerns of dissection of aorta. So C-section to be done to prevent that. What do you think? Can they have normal delivery, Sumati?
No, ma'am. Actually, coarctation of aorta, the indication for C-section is coarctation of aorta as such, because there is a risk of having a aortic dissection as there. So as such, we go in for a cesarean section. We have had a patient with coarctation, but ultimately we went in for section, but we lost the patient in spite of having a section.
So,
the mortality is more in Caucasian because of the resection. So
when I
that
went
is
through the literature, there are some cases where they have vaginal delivery under close monitor, avoiding valsalva. So the concerns are that risk of dissection of aorta and rupture of aneurysm. So we may have to go for C-section. So before concluding, just overall in a heart disease, what is the role of cesarean section in heart disease complicating pregnancy? We always want only vaginal delivery. When do we do advocate cesarean section in case of heart disease? So
only for obstetric indications, ma'am.
Apart
from it, we have primary pulmonary hypertension, uncorrected coarctation of aorta, severe pulmonary hypertension, Marfan syndrome with aortic root dilatation. These are the indications apart from non-obstetric causes for C-section.
In acute severe congestive cardiac, as Dr. Deepa was telling, when the patients are hemodynamically unstable and all the thing we may have to do. Otherwise, severe symptomatic aortic stenosis, Marfan syndrome, and its aortic root dilatation is more than. So that is about the thing. So what are the conditions we advise against pregnancy? We have already talked about the WHO model 4. So we all know it's a primary pulmonary hypertension, Eisenmenger, Marfan. So when conditions where all we have a high mortality, we advise against. So it has been brought up earlier. So I'll come to the last case. I don't know why it is coming so small. So this is a case of a 32 years lady. She was having on I don't know. Her BMI is, oh sorry, it has come. BMI is
next slide.
Oh, no, this is it. So this 30 years lady in a postnatal ward, suddenly she complains of breathlessness 2 days after her vaginal delivery. She was reporting dyspnea and fatigue for the past 2 days, and she was thought to be normal. Suddenly she found to be dyspneic and hypoxic with the oxygen saturation of 86%. Her antenatal history was uneventful, except that last 1 week she had a mild elevation of BP and she had a labetalol tablet and for 200 milligram twice daily, and she delivered normally. What is your clinical diagnosis? What are the conditions you have to rule out?
Embolism.
She was a 30-year
peripartum cardiomyopathy.
Peripartum cardiomyopathy.
Cardiomyopathy.
Other things we have to rule out also amniotic fluid embolism, so the postpartum embolism, pulmonary embolism, we have to think. Being a cardiac heart disease complicated, and here we'll just straight away go for peripartum cardiomyopathy. So this woman, we suspect it is a peripartum cardiomyopathy. Our suspicion should be there. Unless we think about it, we will not be diagnosed. It is a diagnosis or exclusion. This woman was dyspneic and her blood pressure was 156/88, pulse rate was 90 with a raised respiratory rate of 24, and her saturation was 95% with the nasal oxygen, and no cough, muscle tenderness and thing. So what are the investigation you will do to clinch the diagnosis, to rule out other causes, pulmonary embolism, other thing? How do you rule out and how do you think it is a case of peripartum cardiomyopathy? Dr. Tennarsi?
Ma'am, first the patient should undergo a detailed echocardiography by cardiologist. We should look in for ejection fraction. We should look for end diastolic dimensions. We should look in for any other valvular abnormalities are there. From the echocardiography, you could come to the diagnosis of peripartum cardiomyopathy after ruling out all other causes.
So actually she had an ECG which showed a normal sinus rhythm. X-ray showed a cardiomyopathy with vascular congestion bilaterally and mild pleural effusion. She had a CT scan because they wanted to rule out pulmonary emboli, and echocardiogram showed an LV ejection fraction of 35 to 40%, and the diagnosis was peripartum cardiomyopathy. Why? Because we have all we have talked about cardiomyopathy so far. I just want to know this woman, what are the risk factors for cardiomyopathy, and on diagnosis she was admitted in ICU. So what do you mean? What are the risk factors in this particular patient which has been cause for, which you can consider that may be cause for peripartum cardiomyopathy? Risk factors.
Is elderly, obesity, para-2, life-2.
So
he was treated for hypertension,
so preeclampsia, obesity, elderly gravida, and poor socioeconomic group, all these things. So this women had other investigation which may be helpful, or N-terminal pro-B type natriuretic peptide. They say if it is elevated, it is mostly of diagnostic of postpartum peripartum cardiomyopathy. This patient, when she was admitted in ICU, huge conflict and clash by relatives. They were blaming our wrong management. Why not diagnosed earlier? So this is why actually we have discussed earlier with Justin Paul sir, opinion on routine echo in pregnancy. What are the guidelines say? What are the medical legal implications? With that, I think. So each person can tell their own idea. Dr. Deepa, what do you think about routine echo? What do you practice in your institution?
I won't practice.
None of the guidelines say that it should be done. None of the American Heart Association, none has told.
Practically, madam, I'm not advising routine echo in any antenatal patients unless otherwise they are come with palpitations to rule out mitral valve prolapse or some kind of dyspnea, dyspnea and exertions or paroxysmal nocturnal dyspnea. Why I'm not doing so? Routine echo, if you do it, most of the times it won't be done by the cardiologist. It will be done by the echo technicians. Even I have a similar case of a patient who was an asthmatic presented in the later half of pregnancy with dyspnea, but totally the echo was normal. But ultimately after delivery, after 1 month, he had cardiomyopathy. He is diagnosed as a cardiomyopathy. So it is not going to give any benefit. You will be looking for pulmonary artery hypertension. You'll be looking for the ejection fraction or valvular disease. The three things is important. If three things are normal,
Dr. Sumati, what is your thing on a routine echo in pregnancy? Because I tell you, this patient had a mild hypertension, pregnancy-induced hypertension, not preeclampsia. Even in severe preeclampsia, we don't ask for a routine echo. So for a medical legal implication, somebody says the risk factors we're talking, elderly lady, preeclampsia. If you have done, would you be able to predict and prevent?
Definitely
no. So, Sumati, you are for or against doing routine echo?
Routine echo as such is not indicated for all patients who are uncomplicated. But if they have some medical complications, like what you said, that patient is having a mild increase in hypertension, anemia, because hypertension is coexistent with pericardium. You can ask for those patients where you can streamline and pick up those patients and ask for an echo. I usually ask for echo for patients who are severely anemic, persons who are having a preeclampsia. We know that there are people who are having it. So whether it is a hypertensive failure, because the patient had a failure, it's a diagnosis of exclusion. Now that the patient after 2 days is going in for a pulmonary edema and having this, means it could be due to a hypertensive failure where there can be a fluid from the third space into the heart which has precipitated. So we cannot know. So for that patients, we can go in for an echo.
So
if you feel
1 week of increased blood pressure the last trimester, you may tend to have an echo. If the patient is anemic, you tend to have an echo. Dr. Vijay,
elderly patients, obese patients, so we can selectively do echo for them in the last trimester.
Elderly means about 30, 35. What do you consider as an elderly?
About 30 we'll do, ma'am.
Okay. Dr. Vijay Lakshmi is a practitioner, and Dr. in Thuthukudi, what do you do in your practice?
Normally, if we are having any heart disease complication, we will refer.
Okay. So routine echo, we don't go for a low risk women. That is it. Dr. Tennarisi, you have told already your thing.
Ma'am, my personal opinion is to do a screening echo, ma'am, because once the patient becomes symptomatic, they end up with a problem, ma'am. They present with in a late stage with congestive cardiac failure, acute pulmonary edema. In that case, in that scenario, it is often difficult to treat them and to bring them back to normalize.
What I'm trying to find, if you are going to do an echo, when do you want to do? See, only symptomatic, Dr. Deepa is telling Dr. the thing. So I'm not asking about some anemia also, somebody wants to do, preeclampsia you want to do. If the patients are low risk women with no other complication, just obesity, BMI is 30. If you are wanting to do, when do we do? Do we do in the second trimester, third trimester, or when do you want to do?
Ma'am, I would like to do it in the around 32 to 34 weeks, ma'am. The period.
So indirectly, it wants to make you say that the echo which you have done is normal, because the echo changes only will come when you have peripartum cardiomyopathy. So it's to protect yourself the medical legal implication, not to protect the patient from peripartum cardiomyopathy. That is what I was trying to find out from various panelists, what is their idea of doing an echocardiography in various. So I asked my cardiologist, he was telling, madam, you do it in the second trimester, madam, he said. Then when I was asking, insisting at what time, okay, late second trimester, he was telling. But he was telling me, government has made it mandatory. It's not, government has not made mandatory. Only the corporation set up in my Chennai corporation, they are doing as a routine. So we should know that in a patient, if you should have a low threshold, as discussed earlier, if a patient is having mild dyspnea, palpitation, or any complaint which is little overlapping, we like to do a thing. I don't think we need how it is managed. Everybody knows multidisciplinary approach. I just ask about what is the advice regarding follow-up, contraception, breastfeeding, and subsequent pregnancy. One person can tell the thing. Follow-up.
And regarding follow-up, ma'am, the patient should be followed up for at least 6 months postpartum, ma'am. This peripartum cardiomyopathy. If the systolic dysfunction returns to normal, then she can have a next pregnancy. If it is going to persist, then we can have, there is a high chance for recurrence of peripartum cardiomyopathy in the subsequent pregnancy and carrying a very high mortality rate.
Even if the left ventricular function becomes complete recovery, still the risk factor, we don't know, risk reason for peripartum cardiomyopathy is unknown. So many factors are there. So I may be very guarded in saying that better her should not to have conceived at all. So it depends upon her thing. So contraception, as we are told earlier, a non-estrogen method of contraception. And some of the studies say breastfeeding is avoided. But the studies are that even with breastfeeding can be allowed in a case of peripartum cardiomyopathy. I think with all this, I want each panelist to give one take-home message on heart disease complicating pregnancy. Start, Dr. Deepa.
So antenatal risk assessment is the main thing we can see. As you said, many of the symptoms will unmark. The first time the cardiac disease unmasked in pregnancy. So the risk assessment in each visit is probably we can pick up earlier rather than doing a routine test.
Dr. Vijayalakshmi.
Pre-pregnancy counseling is very important. Suppose the patient is coming from the childhood age, we have to give, before marriage, we have to give the pre-conceptional counseling with the cardiologist opinion and both the couples we have to give.
So you evaluate the functional status, optimize the medical treatment, pre-conception counseling, where needed, corrective cardiac surgery should be done. Sumati?
My take-home message is what Sumati Sandilkumar has told, ma'am. We'll have to take a proper history taking and diagnose heart disease because most of the patients are missed in diagnosing a heart disease as such. So they have to be diagnosed earlier and everybody should have a stethoscope. Most of the obstetricians do not have a stethoscope. I just have a fetoscope or a fetal Doppler to find out the FH. So they have to have a stethoscope and auscultate clinical history probing, diagnosis of heart disease, pre-pregnancy or during pregnancy, at least the first visit itself, because most of them are getting booked in the first visit. And that has to be done. And if they have been diagnosed, we will not have much of mortality. And we can do the corrective surgeries, like you can optimize if there is a person with a heart disease where you want to have a echocardiogram or a team, you will have to involve the whole of team with a multidisciplinary team. Now that we have a cardiac registry and we have a rapport with most of the cardiologists throughout the districts and in the district each district has got a medical college. So they have a multidisciplinary team with all the registries together. We can discuss and have a better outcome. Actually, we have a patient with Eisenmenger syndrome in our hospital who has delivered by cesarean section and the mother is fine. The baby is just 1 kg, so she's staying in the hospital for more than 40 days. But as such, she has come out with a good outcome because with a multidisciplinary team where we can discuss with the cardiologist over phone using the telecommunications. And so we are able to give a better outcome. So having a multidisciplinary team involving all the cardiologists because it is all available throughout the districts with a cardiac registry, we can have a better outcome. But one thing is we should not miss a diagnosis. Many of them, I have another patient diagnosed at 32 weeks with a congestive cardiac failure. She has had the visit antenatally 2-3 times, but she has not been diagnosed as a patient with a heart disease. She's an MS with MR with failure at 32 weeks. So this happens even now in tertiary centers. So if we are able to pick up cases earlier, we will be able to have a better outcome.
Okay, Dr. Tennarisi.
Vaginal delivery is a safer mode for patients with heart disease. And we should give appropriate counseling regarding contraception or counsel them for interval sterilization.
Okay. Dr. Aarti?
Yes, ma'am. Like many pregnant patients are obese also, ma'am. So, like to find out small murmurs, it's sometimes difficult. So, if we go for a routine echocardiography, also it's not bad. And proper follow-up of the patients, and we can take care of them, ma'am.
Dr. Anita Tamarichil.
Yes, ma'am. Yes, ma'am. So our job is not over successfully conducting the delivery and managing the cardiac events, ma'am. We have to advise her regarding the future pregnancies. So contraception and whether they have to undergo a surgery before planning their next pregnancy. They had a very bad course. We have to plan for them. We have to help them planning for the next pregnancy. That is very important.
So to conclude, a pre-pregnancy counseling, diagnosing earlier, the early antenatal visits, and effective proper plan for the management, the antepartum period, intrapartum, and not to forget about the immediate postpartum period. The peripartum period is very important. That is the time 5 minutes after delivery, the sudden, pooling of blood into the heart causes cardiac failure. That should be very taken care of. So postnatal vigilance for congestive cardiac failure should be a problem. With that, I think I just thank all my panelists for a wonderful interaction. Thank you all.
Thank you.
Thank you, the team, TNFOG, for giving us an opportunity. Thank you, team.
Thank you, Premlata madam. Fantastic. Thank you. And all the panelists.
Thank you, ma'am.
Thank you, ma'am.
Thank you, Premlata madam.
Okay,
and thank you all the panelists. We now come to the end of the day.
Chitrakala, 1 minute. Questions pottaviya, third session.
Third session. Ma'am, நீங்க stop share பண்றீங்களா?
அதுதான் என்ன வரல.
Second session oda winner வந்து Sherin from Chennai. Papa, Harry. Papa. Let's first one about Papa. Done, Pa. Thank you. Voting in progress. வரல. Regarding the heart disease in pregnancy, which of the following statement is true? Epidural anesthesia is not advisable. Women advised to have combined pills for effective contraception. Pregnant women with congenital heart lesions
should have anomaly scan, screening, and for fetal echo. Operative vaginal delivery is contraindicated.
Yes, Chitrakala, you can stop. Yes. After the vote of thanks, the third session result will be announced. Vanita? Yes, now I invited Dr. Vijayalakshmi Gnanashekaran for vote of thanks. She is the Associate Professor, Department of OG, ACS Medical College, EC member of OXY and the Secretary of OXY in 2020. She is the Honorable Treasurer of TNFOG 2021, Field of Interest, High Risk Pregnancy, Adolescent Gynecology and Infertility. Dr. Vijayalakshmi.
Thank you, Sampath Madam. Nandri மறப்பது நன்றன்று. So நன்றி சொல்வதற்காகவே every month உங்க எல்லாரையும் meet பண்ண வைக்கிறாங்க Sampath Madam. Thank you all so much. It's really a privilege to propose the vote of thanks to the August gathering every month. First of all, I would like to thank dear God. Thank you, dear God, for giving us this wonderful CME, for keeping us all healthy and alive. Thank you for this wonderful CME on heart disease complicating pregnancy. My very sincere thanks to both our chief guests and guest of honor, Dr. Alka Kriplani and Dr. Ranjana Khanna. Thank you all so much for sparing the time, for honoring us with your presence in the CME program, and for also helping us in release of this e-newsletter on heart disease in pregnancy. Thank you both so much. Sincere thanks to both our judges, our marathon CME judges, our marathon judges, Dr. Vijayalakshmi Kandaswamy and Nidhi Sharma. Thank you every month for sparing your time. Thank you, dear Rajalakshmi and Dr. Prathipa, both the participants of today's Yuva quiz, Yuva participation, for your talk. Then thank you, dear chairpersons, Dr. Chandra Punaswamy and Dr. T.S. Meena, for chairing the session and sparing your time. Thank you, Dr. Sumati Sendil Kumar, for your update And a very sincere thanks to Dr. Justin Paul. We were really amazed by the registry presentation, sir. Thank you so much. Thanks a lot to Dr. Premalata, madam. Madam, it was a very excellent panel discussion, very useful for all of us. Thank you for moderating the session. And dear panelists, Dr. Deepa, Dr. Vijayalakshmi, Dr. Sumati, Dr. Tennarasi, Dr. Aarti, and Dr. Anita. Thank you all so much for your presence, for the wonderful discussion that we had, and for the very clear take-home messages that all of you gave. Thanks a lot to each and every one of you. And for the entire evening's program has been coordinated by our sweet coordinator, Dr. Vanita. Thank you very much, Vanita, for it. And the success of all this program lies with the planning of our fantastic and very, enthusiastic secretary for whom TNFOG is her breath. So like that, she takes care of TNFOG. Thank you, Sampath Kumari madam, for yet another nice CME program. Thank you, dear President, Dr. Anjalakshi madam, for giving everybody a free hand to do everything very nicely and always encouraging everybody. Thanks a lot to the TNFOG EC members. All of you have been so supportive in doing all the programs. And dear delegates, thank you all so much. Without you all, no CME program is successful. Thank you all so much. Thanks to Shield Pharma, all the pharmaceutical people who are in charge in Shield Pharma. Thank you so much for the link, the sponsor, and all the help, and for the release of e-newsletters, which you always help us in doing. Thanks a lot to everybody. And for the office people who are there behind the scene, whom we really do not mention by name because they are there. They are the pillars who help us organizing. Thank you, office people who do it for us. And if I have left anyone by mistake, kindly excuse me. Nandralladhu andre marappadu nandru. Tavaru seidendal manichidungo. Thank you.
Fantastic. You have to thank Shield for the prizes also.
Yeah.
Third session. Question potre.
So third session question, and what are the prizes, ma'am? Adiyum sollidunga.
Chitrakala.
Yes, ma'am. Yes, ma'am. 1 minute, ma'am.
ஒரு வாட்டி BP apparatus, glucometer, pulse oximeter.
Rotation.
Repeatedா வந்தாங்கன்னா அவங்களுக்கு தகுந்தாப்புல மாத்தி கொடுக்குறாங்க. பட் எல்லாருக்கும் அவங்க வீட்டுக்கு போயிடுது.
மேம் winners மேம்.
முதல் ரெண்டு சொல்லிட்டேன். நீ எனக்கு தெரியலையே கண்ணுல. தேர்ட் செஷன் தான் வேணும். ராஜலட்சுமி from தூத்துக்குடி, ஷெரீன் from சென்னை ரெண்டாவது செஷன். மூணாவது செஷன் தான் தெரியாது. போட்டுட்டியா? மூணாவது ரமா பிரியா from சென்னை. ரம்யா பிரியா from சென்னை. Okay. Every Dr. Ganesh, Shield people, they will give the prizes. Unga phone number vachu address place panni, they will come and give it to you. Thank you, winners. Congrats, winners. And thank you to all. Premalata madam, super pandinga. Sumati kalakita. Both Sumati. Sumati appappa kaana poitalum appappa point vandu soltaanga. Deepa and Sumati. Thank you. Anjalakshmi madam, thank you. Vijayalakshmi, thank you. Chitrakala Sajita, thank you. Shall we close? Good night to all.
Thank you, ma'am.